Namaskar. So, greetings from Indian Academy of Pediatrics. Let me thank the organizer of Asthmacon, especially our East Zone Vice President, Dr. Atanu Badra, Kaustav Nayak, and all the team member of Asthmacon for organizing this wonderful Asthmacon conference. What I'm going to discuss for the next 30 to 40 minutes is about a management of an acute exacerbation of an
Hello, Dr. Atanu. Am I audible?
Yeah, I can hear you. Yeah.
Yes, doctor. I wanted to share my screen for today. Kindly see. Okay, doctor?
Okay.
Okay. Atanu, you are in airport or car?
না এয়ারপোর্ট থেকে বেরিয়েছি, but I am on the.
Good evening. Join call.
Namaskar. So, greetings from Indian Academy of Pediatrics. Let me thank the organizer of Asthmacon, especially our East Zone Vice President, Dr. Atanu Badra, Kaustav Nayak, and all the team member of Asthmacon for organizing this wonderful Asthmacon conference.
Doctor, is the
What I'm
screen
going to
visible?
discuss for the next 30 to 40
Screen is
minutes
visible, but it's
a management
whether it's moving on now.
asthma from
Doctor, it's a
OPD,
video.
emergency department,
Okay,
and
it's a video.
PIC.
Okay,
Yes,
then
doctor.
it
The
will be
sound
Again, a
is
greeting
there, no,
from
doctor? The sound.
Indra
sound
Prestigious
is
Indira
okay,
Gandhi
the visuals are also.
working as a professor and in charge of
Yeah,
pediatric.
yeah.
না না তুমি আমাকে বলো তুমি ফ্লোটা কিভাবে রাখবে ফ্লোটা না না একদম একদম ঠিক করে নাও একদম ওটাকে ঠিক করে ফেলা যে
কি খাচ্ছিস? এত তাড়াতাড়ি খাস না।
হ্যাঁ, অভিনন্দন, গুড ইভিনিং।
আস্তে আস্তে খা।
ভিডিওটা অফ কর, শ্বেতোৎপল।
কেন খাবি?
ভিডিওটা অফ করে দে, ভিডিওটা অফ করে দে। Hello, hello, Abhilasha, can you hear me?
Yes, doctor, I can hear you.
Yes. If you can hear me, please start the the recording of Dr. Basavarajan.
Sure, doctor.
We have, Shitotpal, we have checked it out. It's okay.
Oh, it's okay.
Just started.
Just give a ring to those who are supposed to join on the panel link. To ask them to join so that we can start.
Okay, then I am ringing all those people. I am calling them once. Shapunda,
Yes. Call.
Shapunda, Dr. Manocha is also there. Shubhroda and Dr. Manocha, they will be there in
Doctor,
the.
I asked them to upgrade. They need to accept my request. Dr.
Shvetotpal,
Manocha is in the attendee section. She can hear us.
so do it yourself. Abhilasha, Abhilasha, you do it yourself from your end. Don't keep any attendees. Make all
Doctor, I
panelists.
can send them request. They need to accept my request to be promoted. I cannot do it from here directly.
Okay. Shvetotpal, please ring Dr. Manocha.
Yes.
He has to accept the request of upgrading to participant.
The request is sent through the mail, I suppose.
No. Here only. On login.
Here only.
The Zoom.
Okay.
On Zoom only, doctor.
Okay.
Shetatpal, who will be the first speaker today? Who will be the first speaker?
Upon, I think we can start with Dr. Basavaraja sir's recording.
Okay.
In fact, Atunanda, hello. Atunanda,
Hello, follow.
Dr. Vinod Ratagiri has requested to be the first speaker.
Okay,
Hello.
fine. If Vinod sir joins, then he will be the first speaker. Okay.
Yes.
And starting it would not look good to show the recording. So first, according to the picture, first Dr. Vinod Ratagiri, then
Right.
Dr. Vasav Raja, then Dr. Pavel Kundan, then Dr. Raj Tilak, and then Innori. Okay. So we'll start sharp at 7:30. Vilasha, Dr. Rathek is also waiting as an attendee. So please see, or again send him.
Yes, doctor.
Again send him that link to upgradation. Good evening, Shubhro Dada. Unmute korun. Unmute.
Good evening, support. Good evening, everybody.
Good evening.
Good evening.
Good evening, sir.
Good evening. Good evening.
Shetatpal.
Metropolis তুই ওটাকে দাশগুপ্ত কর, অনলি ডাক্তার গুপ্তা আছে, অসুবিধা হচ্ছে বুঝতে। রিনেম করে দে।
ওটা ওরা করে দিয়েছে। আচ্ছা আচ্ছা, আমি দেখছি।
Hello, good evening, sir.
Good evening,
How are you?
Good evening, Subrat sir.
Good evening. Good evening, sir. Good evening. Good evening.
How are you,
Sir,
sir?
today you will be the
Fine,
first
fine,
speaker.
fine, doctor.
Yes, sir. Yes, sir.
You will be the opening batsman of this Asthmacon, and then
Yes,
you will
sir.
decide. And Atanu has to join on the way to Bhubaneswar Airport.
Yes, sir. Yes.
Atanu, in
Good
the
evening,
car.
Vinod sir.
Good evening, sir.
So I
Good
cannot
evening.
see Dr. Manocha. I could see Dr. Rathagiri, but I
Yeah.
couldn't see.
You are driving, sir?
Yes, sir.
Atanu, sir.
Yeah, I am. Yeah, actually, we had a Vaxiodicon in Odisha.
Okay, okay.
So physical program.
Okay, sir.
Sir, I will talk to you later on. NTP का
Yes, sir.
alternative speakers देना होगा.
Jamshedpur, क्या?
Yeah, for Jamshedpur.
Swapan, sir, you are free on that day, 10th?
I don't know. At that time, I will be in this place, Kishanganj, and the net is horrible. So whenever I am in Kolkata, now I am in Kolkata for 2 days, so I accept all the invitations.
Oh,
That is a horrible place, no?
okay, sir. Okay, okay.
So I always
Dr.
request
Rathagiri
Atanu
and Dr.
not to give.
Dasgupta.
Good evening, Dr. Manocha. Good evening.
Hello.
Bhupida, good evening.
Good evening.
Good evening.
Rename, just do rename. Shetatpal, just do the rename.
Yes.
Madhumita has also joined. Okay.
Good evening, everyone.
Good evening, madam.
Good
Good
evening.
evening.
Good evening. Another 4 minutes, we'll start.
Yes. I've changed it. Hello, Dr. Manocha is there.
Yes, sir. Yes, sir. Yes, sir.
Dr. Ratagiri, I'm Dr. Dasgupta.
Yeah.
Good evening.
Yes, sir. Yes, sir. I know.
We have talked so much over phone.
Yeah, thank you.
So how are you doing, sir?
Yes, sir. Fine, sir. Going on well. So,
You are the first speaker, no?
yes, sir. 8 o'clock.
Namaskar, sir.
No, sir. No, sir.
Dr. Manocha, namaskar.
Namaskar. Namaskar.
Manocha sir, how are you?
I'm doing fine. And
আপনার sketches এর সঙ্গে খুবই
sketches are going on. Sketches are going all the time. This I've done today.
Yes, sir. You're just wonderful.
Like,
Yes, sir. Sir has also posted it in our group. You
yes.
are there. Madam, you will be catching train, no, today?
Yes. Today I have to, tonight I have to travel.
So
I have
nice
to
of
pay.
you. So nice of you that you have taken time out of your busy schedule to be with us.
Busy traveling and
Right.
other things.
Where are you going?
It must be very hectic for you, no?
Yes,
Traveling
yes.
every weekend, up and down.
Almost every week I have to travel. Sundays especially, and your branch keeps all your programs on Sundays usually, what I see.
Yes, ma'am.
And-
Right. No, most of the days that the people are practicing here and there. That's why
Yes.
there's no option. And extremely sorry that I next time we will try to get it done on Saturday, no, so that you will be present there.
No, the one advantage of being arranging on Sunday is that there are no other programs. No little
Right.
chance of clashing with other programs. Saturdays
Right.
will be like it will then again clash with
No,
Chinese will clash.
have to announce before and no. So people
Yes.
will arrange accordingly.
Because nowadays there's a plethora of virtual programs, and yesterday only in that mission school there was a lecture on how to reduce on screen time, but I don't know, I'm being forced to, like, every day I have to, there's no other way, I have to sit in front of the screen, forced to sit.
And nowadays webinars are almost on every day.
Yes, that's
sometimes
what-
in the morning,
and,
sometimes in the evening.
Yes.
Not 1, 2, 3 in a day.
2, 3, afternoon, evening, and then for us
Yes,
government VCs like virtual conferences from Shastra Bhavan.
Now I
This
think
meeting,
we'll
that
start.
meeting.
We will start. So,
Okay.
Abhilasha,
Yes, sir.
I'll request everybody to mute yourself. Okay. So, the panel link and the viewers link are given, and it is the recorded one. So, I'll request all of you to mute yourself, and whenever your turn will come, so unmute. So, I think good evening, everybody. Welcome to the Asthmacon 2021, being organized by Kolkata Metropolis Academy of Pediatrics. So we are delighted to have our panelist, Dr. Vinod Rathagiri, over here. We have the president of the WAP, Dr. Subbrata Chakraborty, president of Metropolis, Dr. Noni Gopal Chakraborty, and the senior mentor, Dr. B.K. Manocha, secretary, Dr. Shetatpal Dasgupta. So I'll request Professor Subbrata Chakraborty, President of the WEP, to inaugurate the Asthmacon 2021. Over to you, Professor Subrata Chakraborty. Subrata, please unmute yourself.
Yeah. Thanks, Sapun. At the outset, I thank CIFP, Team CIFP, our President, Dr. Piyush Gupta, immediate past President, Dr. Bakul Parikh, President-elect, Dr. Ramesh, and HSG, Dr. Bashav Raja, for providing us constant support, this platform, and constant encouragement. And this is again a proud moment for us that we are now holding the third Asthmacon. The first two was organized by Coalfield branch, and now it is a Metropolis branch. So my sincere thanks to Satyapal Dasgupta for organizing secretary and Dr. Noni Gopal, and of course very senior member Dr. Manoj Jha, under whose guidance this branch is running. And I wish all the success for this program. And I am sure it will be an extraordinary program. And I also welcome on the dais our eminent speaker, Dr. Vinod Ratagiri, Dr. Bashav Raja, Dr. Piyush Pavan Kalyan, Dr. Raj Tilak, and Dr. Indranil Haldar. So we are going to have an extraordinary program with this galaxy of speakers. So please, I again request and thank everyone. So please proceed. Sapun, now we proceed with the program. Thank you. Thank you, everyone.
Thank you, Professor Chakraborty. Now, Dr. Raj Tilak has also joined. So now I'll request Dr. Vinod Ratagiri to give a few lines of blessings to us. Dr. Ratagiri, sir, please unmute. Please unmute.
Yes, sir. Good evening to all. At the outset, I really congratulate the Kolkata Metropolis Academy of Pediatrics for successfully conducting this Asthmacon. This one, I heard it is third conference successively they are conducting. So once again, I congratulate. And this time you are having 5 speakers. So all are in the field like seniors, Dr. Raj Tilak sir, Pavan Kalyan, and Dr. Basavaraj and Indranil Hawaldar sir, who have accepted our invitation. And the topics chosen is also extremely good, which are very helpful for the practicing pediatricians. I really thank I take this opportunity to thank the West Bengal Association, Pediatric Association President, Dr. Subrata Chakraborty sir, Secretary, Dr. Madhumita Madam, and the Kolkata Academy President, Dr. Chakraborty sir, and the Secretary who are in touch for our academic event, Dr. Satyapal Dasgupta sir. I congratulate all the organizing committee members for taking this event into such a grand one. Once again, I thank and I wish that this program will be very successful and very enriching event for all the participants who are going to participate in this event. Thank you. Thank you, one and all.
Thank you, sir. Now
thank you once again. I forgot Dr. Athanubhadra sir, who is always a constant guide for us. He is the Vice President, East Zone. So I congratulate sir and also thank you for giving this opportunity. Thank you, sir.
Thank you, sir. And now I will request our Professor Madhumita Nandiboni, the Secretary of the WAP, to say a few lines of encouragement. Madhumita, please unmute yourself. Unmute.
Good evening, my seniors and colleagues. It's a privilege that Asthmacon is into its third year, and it has already attained a special place in the academic itinerary of West Bengal and in the national level also. And I wish Kolkata Metropolis, my best wishes are always with the Kolkata Metropolis branch, and I think this Asthmacon will be a great success. And I welcome our speakers of national level, Dr. Ratagiri, Dr. Basavraj, Dr. Raj Tilak. I won't forget Dr. Raj Tilak's sir's help in procuring rabies immunoglobulin for my husband. He went out of the way in Kanpur. I didn't know anyone. I somehow got contact details of Raj Tilak sir, and he helped me. Otherwise, he wouldn't have got that immunoglobulin in time. So yeah, I am indebted to you, sir, throughout my life, and my best wishes, my regards to Dr. Manocha, whom I am meeting though virtually after a very long time. And without wasting any more time, I shall thank you. And my wishes are with Dr. Atanuda and Shopanda also.
Thank you, Dr. Nandivanik. So now I will request Dr. Raj Tilak to give your blessing, sir.
To organize Asthmacon at a national level, hosted by the very branch from West Bengal, is a fillip wherein you can find all the dimensions that ultimately pool into this spectrum of diagnosis will finally be divulged to understanding of masses. I wish it all success.
Thank you. So that I can see that Pawan Kullan has joined. So good evening, Dr. Pawan Kullan.
Good evening, sir. Good
So
evening.
welcome to the Asthmacon 2021. Now I request Dr. Atanu Bhadra, the Vice President of the East Zone, the CIP, to give his word of blessing. Atanu, please.
Thank you, Shapon, our Honorable EB from West Bengal. Asthmacon was initially we had hesitated to whether it would be very interesting, either it would be interesting to all the pediatricians, but of course it has been a hit. And this time I thank the respiratory man of India, Dr. Vinod Ratagiri sir, whose constant encouragement and his suggestion of the topics, my dear friend Pavan, and Raj Tilak sir, and of course Indranil. So it would be great academic feast. And I do hope that in the future, Asthmacon would be held in different places of India, and it would be a series of programs. I am just returning from Bhubaneswar, where we had a Vaccine Audicon. So that also has being taken up by different branches of India. It was a Vaccicon first in Calcutta last time, and now it has been, this time it was in a virtual platform. I hope that we continue it on the real platform next year. Thank you.
Thank you, Dr. Bhadra. Now I request our mentor, Chief Mentor, B.K. Manocha. He is very close to us and he is very useful. Already he has shown us his sketch today. So, sir, please proceed.
Good evening, everyone. Just few moments ago, I was thinking, I had read a article that was read about 15 years back, that in future people will not be going to the offices, they will all be working from home. So that thing has come true after this epidemic. It's not only the offices, it's the schools, it's the doctors who are all seeing patients online, virtually. And here, all our conferences also, we are meeting virtually, you see. So about this Metropolis branch, it is still, though it's in a toddler phase, but it has reached quite great heights. And this Asthmacon conference has become so popular, and it gives very good lectures, and we can all learn a lot from it. Thank you very much, and all the best for the speakers. Thank you.
Thank you, Dr. Manocha. Now I'll request Dr. Noni Gopal Chakraborty, the President of Kolkata Metropolis Academy, to give his blessings and say something, please. Unmute yourself. Nonida, please unmute yourself.
Good evening, everybody, and respected dignitaries for their kind presence to success this program. And I am thanking everybody. Please continue the session. I am requesting Shapon to continue the session.
So thank you, Nonida. Now I will request my friend, Dr. Pawan Kollan, to say a few words, sir. Before you talk.
Tell me, sir. Before I
Yeah.
talk, okay. Thank you. Thank you very much, sir. I thank the Kolkata Metropolis Bank. You are always the trendsetters. Now, sometimes when we make a movie in Andhra, we say a trend-setting movie and you earn much more. But yet now, as you started with Mexicon, it has become a hit. Asthmacon is a hit. Whatever you are touching is a hit. So I think the most of the things would be coming from Calcutta, because what we have read from our anatomy days, all textbooks are from the Calcutta people. My teacher was a Kolkatite, so I am very blessed to be in the state of Calcutta. Only thing is that I am missing the ambience and the look of the Calcutta, which I have not seen the Calcutta as such. Before Atanu sir leaves the vice president post, I would like to visit once the Calcutta and see the ambience. And I am very thankful and grateful for giving me this opportunity, and it would be definitely, we'll try to do some justice to the pediatricians of the Calcutta as well as the whole country. Thank you, sir.
Thank you, Dr. Pawan Kollan. In fact, it will be our pleasure to receive you in Kolkata Airport very soon. So next, but not the last, Dr. Shetotpal Dasgupta, who has relentlessly worked for this Asthmacon. So Shetotpal, just a few lines.
Yes, thank you, Shapunda. Thank you very much. In fact, it was a group effort, and it was nothing individual for me to do it. We all, myself, Nonida, Dr. Arnob, they were all, and Dr. Shane, Roger Shane, he was also there. So we all tried our best with the blessings of you all the seniors, including Subrotoda and Shapunda and Dr. Atanu Bhadro. So it was possible because of a team effort and not any individual effort from my side. So I had tried to do my level best. Still, it was an effect of the team effort. So now, first speaker, sir, is Dr. Ratagiri. I will request you to kindly introduce Dr. Ratagiri, and we will start the scientific session, sir.
Dr. Ratagiri sir is our mentor actually. He is the man behind that NTP program, and he is a very nice person. So I had requested him to send me that particular NTP, and he immediately sent it. And sir, I'm really thankful to you. He's the professor of Department of Pediatrics, Karnataka Institute of Medical Science, the KIMS, Hubli, and his main area of interest is respiratory and critical care. And today he has become the chairperson of our 2021 Asthmacon. So now Dr. Shetotpal Dasgupta, Dr. Ratagiri will take over the scientific session. So over to you, Dr. Ratagiri, sir.
Thank you, sir. Thank you very much. Shall I share my this thing, sir?
The scientific session with our opening batsman, Professor Vinod Ratagiri, sir.
Sir, is this slide is visible?
It is visible and you are audible too.
Okay, sir. Yeah, once again, good evening to all the viewers of this Asthmacon. At the outset, I again take this opportunity to thank the Kolkata Metropolis Academy of Pediatrics for taking up this third Asthmacon. And I really thank Dr. Sapan Rai sir for giving such a kind words for introduction of mine, and also all the organizing members, especially Dr. Svetopal Dasgupta sir, who is constantly in touch with me regarding this event, specifically related to the topics and the speakers. And also Dr. Atan Budra sir, who is always behind these events. I think he is the most successful vice president of East Zone. So many programs is in his hands, and he is actively involved in all these events. Thank you, sir. So now I will move on to the topic of today's talk. That is the first talk. That is which guidelines on asthma suits best to Indian scenario. appears to be a bit difficult, at the same time tricky also. Now, so many guidelines are running regarding asthma, not only in national level, even at international levels also. Now, we all know that the asthma, not only in the Indian and also all across the other countries in the world. Though this picture is an old one, but still it holds good in the sense the prevalence of asthma is still high, except in few countries like the one which like Canada and some other Western countries, though they have showing some lesser admission rate in relation to exacerbation and also mortality. But as such, the number of cases are still increasing, especially in children, and more so with the Southeast Asian countries, especially India. We are seeing the number of cases of childhood asthma is increasing. And if you see the international study on asthma and allergy in children, it has been shown that the number of cities taken is more than 14, but the prevalence rate is varying across the country from 7 to 20%. So that's what is being highlighted, and it is still increasing in this era. Although the true burden of asthma in India is not known, but recent study, which is being quoted by Sandeep Salves, has said that estimated around 37.5 million. Now, if you take world, the number of cases, it is 300 million. So 1/10 of cases are in India. Specifically in relation to pediatrics, as I said, the ISAC study has reported 7 to 20%, but more important one is the Dr. Parmesh's study from Bangalore, which has been quoted as one of the best one, saying it is increase in the prevalence from 9 to 29.5% in the last 10 years. That means the number of cases in metros, especially in metros, it is increasing, though it is varying in different parts of country, but definitely we have seen the number of cases are more. But what is more important is though the number, if you see compared to the Western world, it appears to be lesser. But the problem here in the Southeast Asian countries, especially in India, most of these are like over half of these reported asthma children are having severe symptoms. That's the worrying factor. And if you see concern to mortality, the highest mortality is seen in these low and middle income countries, probably because of underdiagnosis and also undertreatment, which appears to be really a challenge for controlling these exacerbation, number of cases, and mortality in related to childhood asthma. Now, despite having been said all this, knowing that the pathophysiology very well and having a very reliable diagnostic tools, and also most importantly nowadays we are having an effective and affordable inhalation drugs, and also more importantly for all of us, we are having both national and international asthma guidelines which are having a good evidence-based approach. Despite all these, it has been seen in clinical practice, not only in India or developing country, even in the advanced country or especially in the Western world, these cases are poorly managed. So that means the guidelines are there, but clinical implications are not much. And what is to be delivered to the patient is not being there. Probably there are a lot of issues which are associated. And ultimately, once we have a good guidelines, that has to reach to the patient when it is required. If it is not been reaching, then there is no point of having a guidelines. So what are these drawbacks, or what are the barriers associated with these problems? We are having definitely good clinical guidelines, but at the same time, we are seeing that these guidelines are not translated into the patient care effectively. It is being there, Definitely it is increasing in use, but still what is to be achieved is not being achieved. So in next 15 minutes or so, what I'm going to talk is about these various clinical guidelines which have been published in various domains, specifically related to childhood guidelines and their implication in clinical practice, how they are having problems, why it is not being reached to the patient care, what are the barriers and what are the gaps in these guidelines and clinical practice. I'm also going to highlight really the challenges what we are facing as pediatricians, specifically in India. And then I'm going to highlight some of these merits and demerits of various guidelines, which we are intended to follow these guidelines. And lastly, I will highlight some of the medication, which is the backbone of our asthma management in various guidelines, how it is being there. And then we will analyze, translate what is more effective guideline for us, which is needed for Indian pediatricians, that I'm going to highlight. Clearly, now if you see, the guidelines are having been there around almost 25 years, and all of these guidelines are clearly and positively impacted the level of care of asthmatics, definitely. Because in 90s, before 90, there were no guidelines. When these guidelines start appearing, the number of cases, especially exacerbation cases and mortality, definitely has shown decrease in the trend. The first guideline, which was appeared in New Zealand and Australia, that was the trend setter, and followed by, there are plethora of guidelines by various bodies in international arena, and all these have a common content and the evidence-based approach for managing childhood asthma cases. The most significant among these are XENA guidelines, which we all know, Global Initiative on Asthma Care, and also the British Thoracic Society guidelines. These two guidelines are having a clear and precise understanding of the nuances, that is even the microscopic changes of asthma therapy. It is being highlighted in these two guidelines. These are most comprehensive and having thorough evidence-based approach towards a practical treatment of asthma cases. And they have formed the roadmap for the diagnosis, treatment, and follow-up of patients with the asthma. Now, having been said all this about the guidelines, one word which is needed is about the children. Asthma in children. Historically, like any other disease, in asthma also, most of these guidelines neglected pediatric part. Only in 2003, the first clear-cut guidelines and dedicated to pediatrics came from Canada. That was the first in 2003. And subsequently, again, most of the Western world started having guidelines related to pediatrics like UK, USA, New Zealand, Australia. And now, again, most importantly, every year updating messages we are getting for asthma in children is from, again, two more, the XENA guidelines and British Thoracic guidelines. These asthma guidelines, specifically in relation to pediatrics, describe pharmacotherapy as a critical component of management in children, both taking into consideration short-acting beta agonists, which are like a reliever medication, and inhaled corticosteroids, which act as controlled medication to achieve the asthma controllers. In pediatrics, most of the time we use the SABA, which is being used, short-acting beta agonist. Commonly it is being used, but adherence to the other medications like inhaled corticosteroid, which required constantly, there is a problem. We are having big problem when it is to be used continuously. Although the pediatric issues have been highlighted in all guidelines, and specifically these two guidelines in recent times, there are some problems still. Specifically, suboptimal control remains a problem in children. The guidelines, most of these, specifically in relation to children, have taken care in defining how we need to make a diagnosis of asthma in children, specifically taking into consideration both subjective and objective measures. nowadays. Earlier it was more of subjective, and now it is even the objective assessment is also more important. And second part which they have taken considerably is about the management. That is the management at initial part, immediately at diagnosis, then other medication, when to add-on therapies, that has been highlighted, and also the maintenance and reliever therapy is being included in most of these guidelines. What are the differences, what we are seeing in various guidelines, and what are the key areas we need to look into? If you see the most of the guidelines across the world, there are still, as I said, even in the Western world, there is a difficulty in implication of these good guidelines, specifically in regard to insights, attitudes, and perception about the asthma and its treatment. Most of the time, we are seeing the problem because of some like cultural or educational related this thing. And apart from that, in Southeast Asian countries, in African countries, we are seeing economy is also a big burden while managing these issues. Now, if you see the Indian context, some of the studies which have been shown that the adult part, this what I am highlighting is adult part, where they have seen that most of the asthmatics are presenting with exacerbation of asthma, almost 67%. This indicates that there is definitely a poor control of asthma. And this needs to be highlighted while managing these cases, specifically the proper approach, stepwise approach, that has to be highlighted, taking into consideration all these physicians. We need to teach first, or we need to acquire knowledge before we treat our cases. What is the appropriate way we need to manage these children? Then only we will be able to control the asthma cases. The other things which has been highlighted in that study, that the uptakes of bronchodilators, inhaled corticosteroids, and influenza vaccination have been found to be very, very low in India. So having been said that, although there are multiple guidelines, but all these guidelines have given a clear level of uniformity in approach and in content. But these guidelines have also stated that they can be modified marginally to suit the local condition. This point we need to take when we are making our own guidelines for our own people. That has to be taken. This is more obvious in a country like India, where we are having various cultures and various ethnic diversity is there. To accommodate all these, we have to little more modify these standard guidelines to suit for the local needs of our patients. In 2018, the Global Asthma Network has given that a report, and they have published that to get, though we are having good guidelines, but we are not able to reach the people who are in need. How we can achieve this one? And they have proposed these 8 components that is being called as proper diagnosis of asthma, that we should not overdiagnose or underdiagnose. And then we need to make locally appropriate asthma guidelines. Then the treatment, standard treatment for the asthma severity. Based on that, we need to look. And more importantly, they have given importance for these 3 points. That is patient education, and then monitoring once patient is on the treatment, what is the outcome. And more importantly, they have highlighted that there is a need for appropriate training of healthcare workers, including the first attendees, that is the general practitioner and practicing pediatricians who are taking care of these children. All of them should be trained in these guidelines. And more importantly, they also highlighted the importance of the government, where, because many a times we are seeing there is a problem with the economy and they may not be able to purchase all these drugs. So there should be an uninterrupted supply of these quality assured essential asthma drugs like inhalers, spacers, drugs, all should be available at government hospital. Then only we will be able to manage these cases very well. And lastly, we need to have a checklist where we can evaluate every year how best we have performed this year and next year, and what are the drawbacks in this year, and how we can overcome these problems in future. These are the 8 components which they have given in global report. So having been there, these guidelines and the clinical implication problems, so we need to know what are these gaps. Definitely everywhere there is a significant gap between guidelines and the clinical implication, especially based on these prevailing practicing behavior of our pediatrician and the practitioners. Definitely there is a gap. So we need to reduce that gap. How well? By understanding to the extent of the disease and also various risk factors associated with this one. If we reduce that one, definitely the outcome, the implication, and the receiver end will be much benefited by this one. So the highlight of this one is most important one is it is the non-adherence of these guidelines. Not only we are always telling that the patients are not adhering. It is very important to remember that it is not only the patients, even the treating physicians should be adhered to these guidelines. That is the most important thing what they are highlighted even in the global asthma network. So both the treating doctors and patients should be trained in a well way so that the management of these children with asthma will be very well taken up. So Dr. Varinder Singh sir has given in his report saying that what are the main barriers we are seeing as pediatrician towards the patients. So one of the important barrier which we are seeing as a whole in country is these large number of patients in India still consider asthma as a stigma, which is applicable everywhere across our country, and therefore they will conceal most of the time disease. The second important barrier is the many believe that these inhalers are habit forming and they feel that they are the strongest medicines. So they may cause some side effects. That's the worry of most of these patients. This we need to overcome. That has to be, again, educate the patients and patients' relative regarding the importance of these drugs and about the side effects of how less they are. And more importantly, many a times we are seeing the diagnosis is also either overdiagnosed or underdiagnosed because the various clinical manifestations they come. They may come with only cough or they may come with only breathlessness or wheeze. Depending on the clear-cut manifestation, we have to make a clear-cut diagnosis of asthma and accordingly we need to manage. And lastly, the most important barrier he has quoted that most of these patients, when they start taking treatment, especially they will take when the symptoms are more, they will start taking. The moment the symptoms are reduced, they will stop that one. This will have a disastrous impact, specifically in relation to the controllers where we need to stress for these patients because they need to take for a longer time. So then only it will be under control. That point will be problematic if this is the attitude of our patients. So having been said all these important barriers in the patient perspective, but still in the last decade, many of us have worked, specifically in the metros and bigger cities, many patients have overcome and now they are regularly following up with the inhaler therapy, and it is all because of educational therapy. And education is the most important tool for managing these asthma children. That's about the patient perspective where we are having barriers. We are having barriers in terms of the treating physicians also. There are many studies which have come up, including in India, where it is being said that even physicians themselves are confused which one to follow, how we need to. They may not be having enough knowledge when to diagnose, how to diagnose, and what are the stages, and at what stage we need to give proper treatment. Now, if you see the GINA guidelines, every year it is updating, and we need to update our knowledge, including our practicing pediatrician. Then only we can overcome all these problems. And ironically, it is being said, most of the societies or bodies are spending a lot of money for preparing the guidelines. But unfortunately, these guidelines which are being prepared, they have not been implemented properly in the clinical practice. So it is utmost importance should be given that these guidelines should be implicated properly, and we need to give certain funding, certain time for training our pediatrician and practitioners so that they can implement it at right time, right place for the right child. So that's how we can improve our management in our children's. Another study from Sandeep Salve sir, which is almost 91% of asthmatics in India, they are saying they are having asthma, but they have been controlled. But unfortunately, when they have been assessed objectively, they were still having the asthmatic symptoms. Similarly, almost there was 93% school absenteeism because of the improper management of these cases. Most of these are adult patients, and 75% of these asthmatics are having not been the lung function test, which is the objective measure of assessing these children. And lastly, only 36% of these are having the inhaled therapy. Remaining still, they were using oral therapy. So again, that's the reason we had a very poor outcome in India. These things we need to address while managing in future, specifically the children. And now, having been said all these, there is, as a pediatrician, we are facing a lot of children. And in fact, we are having more number of cases than adults as far as asthma is concerned. But we are having real challenges, and these children. Now, if you see this, either we can, if we are going properly, then there will be a good chance of making a right diagnosis. Otherwise, it will end up in either over diagnosis or under diagnosis. And if you say that your child is having asthma, that we need to educate. It is another problem. And one of the talk by our the senior pediatric pulmonologist, well known, Dr. Raj Tilak, has very well highlighted the various phenotypes of asthma, many phenotypes, how we need to address. If you address these phenotypes properly, then the management of becoming very, very easy. And also the way how they are presenting is also important, like the cough presentation or this wheeze. When it is really persistent or recurrent, then only we have to consider the possibility. Though there are exceptions, but we need to make these points very clear when before we make a diagnosis of childhood asthma. The left half is we are having a lot of challenges in management, including the inhaled therapy or oral therapy and choice of right device, because it is a growing age. At different age group, we need to use the different devices. That has to be highlighted. And as we are seeing now, the nebulization, we are having so many respiratory infection. Many people are now using these nebulization even in the home without the knowledge of this one and ending up in the problem. These problems we need to highlight properly, and use of steroids, appropriate dose, appropriate way we need to use these steroids. Otherwise, we'll end up in again problem. And lastly, the third part, which is most important challenge for us, is education. We need to take education ourselves, and then we need to educate the even patients also regarding the management, like how they have to adhere to the treatment, and if they adhere to the treatment, what will be the outcome. That we need to highlight. Otherwise, how they are ending up in problem, that we need to demonstrate them and tell them clearly that these are the problems associated and how we can overcome these. We have to tell to the parents. So these are the various challenges we see in our day-to-day practice in our pulmonology, specifically related to asthma. The other challenges which we see specifically in the children less than 5 years, the making a diagnosis of asthma is very, very difficult, specifically related to use of these objective assessment using spirometry, very difficult. And lastly, we need to take care that many of the patients attend are having a fear that if you start early these inhalation therapy, they might end up with the addiction for these things, that we need to highlight them that they are not going to be addicted for this one. So these things we need to highlight when we are managing these children. Though these are appears to be simple, but these are making a lot of complications when we are making a management of these children. Lastly, I am now moving to the various guidelines which has been there in the various domains of our societies. I just will compare various guidelines. Because of, apart from NICE, the Scandinavian and British thoracic guidelines are being used in these, and then Australia, XENA guidelines and other things are there. But most important for all of this is they are all having same content and they have given importance for same, like for diagnosis and evaluation. All of them have given the clear-cut guidelines for this one. And then many of these, the contents, what is being depicted in this, are most of the guidelines are following except few, like immunotherapy is not being highlighted in XENA guidelines. Likewise, very few exceptions are there in each of these guidelines, but overall, the content of diagnosis and management of these childhood asthma is same in all these, except some wordings may be changing in each of these guidelines. Now coming to the XENA guidelines, which most of us are following, is definitely a good one in the sense they are now shifted to saying when we are managing these children, they use the word control, which is very simple and easy to follow for us. And it is also easy to follow for the patients also. So that's the important thing what we are seeing with the XENA guidelines. So it also makes easy for the patient to follow and report the symptoms. So in the sense, the unnecessary terminology if you use, then they will end up in problem. So that care has been taken in XENA guidelines. Now this is the one which is being highlighted, taken like whether child is being controlled, partially controlled, uncontrolled by putting the various objective assessment they have made, questionnaire, and accordingly it is being assessed properly. So this is what is being followed in XENA guidelines. And then accordingly, you need to manage the children. It becomes very simple when you start the assessment properly. Accordingly, you can manage these children. Most important thing these guidelines are highlighting is asthma education. That has to be again continued in these children. And the second important thing is again highlighting in these guidelines is about the self-management. In relation to XENA, the British thoracic guidelines have, instead of controller, they have taken the approach like preventer therapy. One preventer and a reliever. That's what they have given. In other way, this concept is also a good one. It will be, though appears to be underplayed, but it is really in some of the way for many of us is giving easiest way that it has been controller, it has been reliever. Two simple terms they have used: reliever for acute problem, controller for the maintenance therapy. That's again giving much benefit not only for clinicians, even for patients also. It is giving some advantage when you are using these words. So these are, though appearing different, but conveying same messages in these two guidelines. And lastly, the concept of step up, step down appears to be reasonably uniform in both the guidelines. So that's the another important thing which is helping when we are managing these children. And this is about the various steps which are there in almost all guidelines, same, like pharmacological steps 5 and severity level will be 5 or 4, it will be same. And lastly, about the symptoms, how it is being controlled very well on drugs is being maintained almost all guidelines by this one. This is chart showing all these what is being highlighted, and specifically Gina and the British Thoracic Guideline have highlighted about this importance. And lastly, the dose therapy, which is very important for the practicing pediatricians. Both the guidelines have taken care, and we all know that it is the steroids which is very important. And nowadays, so many steroids are available in the market. It is again beclomethasone, budesonide, and fluticasone. Both the guidelines have given the important doses. And to remember that whatever it is, fluticasone is the most important one, and the dose is half of what you are using for like budesonide or beclomethasone. That point you need to remember. To summarize regarding these guidelines, it is most of the time all these guidelines are though appearing different but conveying the same meaning in managing the children. And they have highlighted about the inhaler therapy in all aspects, and also importantly the asthma education and self-management all are highlighted in these guidelines. So can I take another 3 minutes to highlight about Sopan sir?
Sure, sir. Please, please.
So the next one is asthma medication. I'll just go through this one, saying what is more important is, though we are saying the inhaled corticosteroid is very important, very backbone, compared to adults, where now all guidelines have said that even in step 1, step 2, they are using the combination therapy. Whereas in pediatrics, still step 1 and step 2 is using only monotherapy, that is inhaled cortical. That's the major difference which is there. And short-acting beta agonist is the mainstay in pediatric. But again, there is a problem that most of the patients, they will adhere to only this, but they leave the control part. That's the disadvantage that we have to highlight. And the long-acting beta agonist, which is very important nowadays, there are many studies, even in children also, they are using combined like steroids plus long-acting, especially formoterol, which is having short action and longer duration, apart from the salmeterol, which is slower and a bit late action. So many trials, it has been shown both the inhaled corticosteroid plus combination of the formoterol is giving a lot of advantage. But in pediatrics, so far, above step 3 is being used, but below like 1 and 2, still we are using inhaled corticosteroid. And a word about the leukotriene receptor agonist, it is to be used precisely as an add-on therapy in most of the guidelines. It has been highlighted as add-on. Specifically, it is very helpful in those children having asthma plus rhinitis or other atopic disease, which I think Dr. Raj Tilak sir is going to highlight. And the word I have to highlight here is, in India, this is the drug most abused, specifically in adults. And this drug has been now taken up, theophylline. No guidelines have mentioned about this in recent one. And lastly, about the oral corticosteroids, is being used in step 5 when it is not being managed appropriately with the highest doses of ICS plus LAVAs. And then only we are using oral corticosteroid. There is a word about other forms of steroids like methylprednisolone and diplazocart, but not being in clinical practice much. Evidence is not much, except some side effects which has been there. So still oral prednisolone is the drug of choice. And lastly, which is going to be highlighted by our youngster, Dr. Pawan Kalyan, about these biological agents. It has been used in depth in the stage 5. So all these drugs, if you see Zina guidelines, has been there in an appropriate set. The only word I wanted to highlight here is in adults more than, or in children about 12 years, the combination inhaler therapy using the steroids plus long-acting beta agonist is being highlighted in even since 2019. All is there and evidence is there. So it has to be used in different stages with in comparison to in children, it is only in the stage 3 onwards. First 2 stages, we are using only inhaled corticosteroid, and reliever is purely again SAVAs are being used. We are not having much evidence. Still studies are going. Probably we may end up or we may take up again same as the adult therapy, which is really giving good results in these children. So out of these, whatever discussion we have now, which one is the best? Again, the confusion still hangs, but I feel preferably both these guidelines we need to take into consideration, and IAP has come forward and given the asthma consensus taking into consideration all these points both in GINA and the BTS, and the latest update one was 2016, but we need to, like GINA, we need to update every year to give a better knowledge for our practicing pediatrician. Similarly, the Indian Chest Society and National College of Chest Physicians have published the National Indian Asthma Guidelines in 2015, which is also again a better one. But unfortunate thing is most of us still we are using these guidelines underutilized, and probably we may have to go for these guidelines very rightly and take up these guidelines in a right way. Guidelines-based asthma definitely, especially for pediatricians, is definitely giving a practical, uniform, and structured approach for managing these children. Very good one. And most importantly, these guidelines are having an opportunity that we can modify to our local conditions, suit them, and use these guidelines appropriately. That's the other advantage. And most importantly, again, I'm stressing that asthma education is most important. We need to spend more time, and also about the self-management of these cases when they are taking medication in the home. This is the most important thing which we need to highlight. And whatever guidelines we are using, these guidelines again having the same meaning. So ultimately it is education, self-management, and appropriate drugs therapy for our children, which will go for a long way that we can reduce the number of admission and also the mortality in childhood asthma. Thank you. And again, thank the Kolkata Metropolis Academy for giving me an opportunity to talk on these facts about the childhood asthma. Thank you, sir. Thank you.
Thank you very much, Dr. Ratagiri. Your rendition was excellent, exhaustive, and you had told about this GINA and BTS so exhaustively that in fact next year hopefully we can meet physically and discuss this over a cup of tea. And any questions, if there are any questions, maybe discuss later on. Now with profuse thanks again to Dr. Ratagiri, I would like to say that the next speaker is Dr. Vasana Raja. He needs no introduction. He is the Honorary Secretary of CIP, and he is based in Bangalore, and he is very much involved in the IIP respiratory chapter. Though he has not been able to be present physically there because of his pressing schedule, he has given us a recording of his speech, which I would request DIAP to start right now. Hello, Avilasha.
Namaskar. So greetings from Indian Academy of Pediatrics. Let me thank the organizer of Asthmacon, especially our East Zone Vice President, Dr. Athanubhadra, Kaustav Nayak, and all the team member of Asthmacon for organizing this wonderful Asthmacon conference. What I'm going to discuss for the next 30 to 40 minutes is about a management of an acute exacerbation of an asthma from OPD, emergency department, and in PICU. I bring a greeting from prestigious Indira Gandhi Institute of Child Health, where I am working as a professor and in charge of pediatric intensive care unit. The learning objective of this session will be: what is acute exacerbation of asthma? Assessment of the severity. How do we assess the severity? We'll take up two clinical cases we come across in our office practice. I'll try to explain how we manage. What are the drugs which can be used in acute severe asthma? Indications for invasive ventilation with the background of a COVID-19, how we need to manage, and with a clear-cut message. As per the GINA guidelines of 2020, the definition of acute severe asthma is basically acute severe asthmas are episodes characterized by progressive increase in the shortness of a breath, cough, wheezing, chest tightness, and progressive decrease in the lung function. They may occur in a patient with a pre-existing asthma or in a first episode of asthma. This is a definition from GINA guidelines 2020. American Academy of Allergy and Asthma and Immunology in the 2020 came out with a definition. It is similar to that of in GINA guidelines only. Acute severe asthma is a condition where there is no response to the repeated course of a treatment with beta-2 agonist. This is an American Academy of Allergy, Asthma and Immunology definition of 2020. As a clinician, once the patient comes in the emergency department, what are the assessment you are going to do it in the emergency or in the OPD? We need to check the vitals, that is respiratory rate, heart rate, and saturation. Accessory muscles use of respiration, you need to look at that. Is it there intercostal retraction, subcostal retraction, suprasternal or retraction? You need to check it. Wheezing, we need to look at the wheezing. Is it in expiration or is it in both inspiration, expiration? Is it a continuous? We need to look at inspiratory and expiratory ratio, dyspnea, ability to complete the full sentences, and level of consciousness. These are a very, very important thing in the practice. What are the signs of impending respiratory failure? Because it gives a clear-cut message to us as a clinician to the emergency. If the patient is having a cyanosis, that indicates that it is an impending respiratory failure. Marked dyspnea or inability to maintain the respiratory effort due to fatigue or a poor air movement with a prolonged expiratory phase. Change in the mental status, especially any respiratory things. We always look at the level of consciousness, lethargy or hesitation. We need to look at worsening of hypoxemia, carbon dioxide retention. This should be referred immediately to the level 3 pediatric intensive care unit for the management. This is which is published in an update of 2021, where the assessment and classification of asthma depends upon the mild, moderate, severe, and respiratory arrest or failure, taking into the consideration of a breathlessness while walking or lying down, sentences, is the baby is able to speak, and taking into the respiratory rate, use of accessory muscles of respiration, wheeze, and pulses, paradoxes, all these taking into the consideration, and SpO2 and all. This is a definition which has been classified asthma into mild, moderate, severe, and impending respiratory failure and all. I'll come to the simplification of this in a subsequent slide. So pulmonary score index is very, very useful in the clinical assessment. You put it into your examination table where are in emergency department and ICU, taking the 5 things into the consideration. One is the rate, second is the wheezing, inspiratory expiratory ratio, accessory muscles use, and oxygen saturation. The score is given between 0 to 3, depending upon the respiratory rate and wheezing. Is it there in the end of expiration or entire expiration, or inspiration and expiration both? Our inspiratory expiratory ratio is 2:1, 1:1, 1:2, 1:3. Depending upon that, scoring is done. Use of accessory muscles and saturation taking into the consideration. If the score is less than 7, it indicates that mild exacerbation. If the score is between 7 to 11, it is a moderate exacerbation. If the score is anything more than 12, it is a severe exacerbation. This is a very, very easy thing. With this clinical background, let's move to the case. Ramya, she is a 5-year-old female child, came with a complaint of a cough for 4 days, no expectation, hurried breathing for 1 day, which is progressive, lethargy for 2 hours. Similar complaints in the past twice relieved with bronchodilator therapy, family history of a mother asthmatic, treatment on intermittent bronchodilator. So when you looked into the anthropometry was normal, respiratory rate was tachypnea, and saturation, capillary refilling time is less than 3 seconds, saturation is 94%, wheezing in the expiratory phase, and heart rate was tachycardia, BP was 88/52, and 82, no abnormality was detected, and clinically we can say it is a respiratory distress. When it comes to the database, it is a 5-year-old female child, known case of hyperreactive airway disease with a normal development, immunized for the age, presented with a cough, hurried breathing, and lethargy. On examination, wheezing in expiratory phase, features of lower airway obstruction leading to the respiratory distress was there. Diagnosis is certain. It's a case of acute exacerbation of an asthma. Next question comes, what should be our management plan? What should be our plan of action? Is it asthma? Answer is yes, it is an asthma. But however, we need to ask, is there any risk factor, any asthma related death? That's very, very important for the planning your management, and severity of the exacerbation as per taking a score of pulmonary score index into the things. We take those things and we need to decide that. So assessing the patient of acute exacerbation asthma, classify according to the severity, treat depending upon the severity, reassessment should be taken after 1 hour, plan for the further management needs to be done. So coming to the pulmonary score index, so this is the pulmonary score index, taking the respiratory rate, wheezing, and accessory muscle activity. So further simplification has been done. So depending upon the age, respiratory rate is less than 6, 30 to 45, more than 6 years, 21 to 35. A wheezing, terminal expiration within a stethoscope, accessory muscle activity is questionable, then we say it is a 1. Score is 2 between the respiratory rate of 35 to 60 in age group of less than 6 years. If it is more than 6 years, it is 35 to 50. Entire wheezing is there in the entire expiration with the stethoscope, and accessory muscle activity, it can be easily visible. And score of a 3 if it is more than 60 in less than 6 years, more than 6 years, it is more than 50. The wheezing is there both in expiration and inspiration. Without stethoscope, maximum activity was there. Score is between 0 to 3, it is mild, 3 to 6 is moderate, more than 6 is severe. So treatment option depending upon the severity, mild to moderate, start the treatment immediately. Severe and life-threatening, stabilize the patient before referring it. Then you need to refer it to the pediatric intensive care unit. Treatment for mild to moderate exacerbation, short-acting bronchodilator. You can give it an mid MDI with 4 to 6 beeps of puffs by pediatric MDI with the spacer. You can use it. Repeat every 20 minutes for 1 hour. Prednisolone, you go upfront with prednisolone within 1 to 2 milligram per kg, maximum of 40 milligram. Assess after 1 hour. Coming back to our child has a moderately severe asthma, started on a start-acting bronchodilator with nebulization with an oxygen, and 3 doses given with the start-acting bacterial over a period of 1 hour. Oral prednisolone started 1 milligram per kg. After 1 hour, the child, which is respiratory rate is 20 per minute, that means decreased, pulses was normal, capillary refilling time was quite okay, saturation is normalized, and the patient is blood pressure and heart rate is also normalized. Tachypnea is reduced, no subcostal or intercostal retraction, no wheezing, breath sounds heard equally on both the sides. So this child was discharged with a reliever medication of short-acting bronchodilator, controlled with a low dose of inhalation corticosteroid. Technique of inhalation, you need to take some time to explain the technique. To inhaler therapy is explained and observed. Prednisolone can be given for 5 days, review after 5 days. Reliever medication as and when required, that's the very important thing. Controller, you can start with a low dose and you can step up depending upon the response. Check for the technique and dose of inhalation medication, that's a very key. And prednisolone, you need not to give it behind 5 days, follow up after 2 to 7 days. Once the patient comes in a follow-up, as a clinician, what are the things you are going to manage it? She was in a symptoms-free and stopped with the prednisolone. Short-acting bronchodilator was explained. Give a reliever medication as and required. Low dose of inhalation corticosteroid needs to be continued for a 3 months, and modified risk factor needs to be explained. So prednisolone needs to be stopped. Reliever medication SOS, controller based on the exacerbation, and your modifiable risk factor needs to be looked at. Criteria for discharge, whenever the pulmonary score index is less than 3 and symptoms, if it is improved, not requiring short-acting bronchodilator, peak expiratory flow rate of 80% of the normal for the best value. Saturation is anything more than 94% in the room air. Adequate resource at home. That is the criteria for a discharge. That's the patient which is made an improvement, which is discharged within a medication. Let's look at another scenario. This is the case 2. The 9-year-old Ramesh is a known case of bronchial asthma for last 5 years. He is already known. Brought to ER with a sudden onset of a cough, wheezing since 2 days. Symptoms are worsening over a period of 2 hours. Child used to get this type of attack once in a month and was on irregular treatment. On examination, breathlessness while speaking, child is anxious, respiratory rate is 60. Mind you, this is a 9-year-old and was marked into costal and subcostal retraction was present. On auscultation, both inspiratory and expiratory wheeze was present in both the things. Saturation was low, 80%. So next question comes, how do you attack this acute attack rate? So once again, go back to your pulmonary score index, taking the respiratory rate, wheezing, and accessory muscle activity, taking that into the consideration. This child was more than 60. That means if the age of the child is more than 6 years, score is comes to 50. It is wheezing was there both in the expiration and inspiration. That means another 3 points. Accessory muscle activity was there. That means score is more than 6. As per this score, but the pulmonary score index is acute attack. This child is fitting into the acute severe exacerbation. So the child needs a pediatric intensive care admission. Take care of airway. Airway was clear. Breathing was looked in. Adequate ventilation was there. Circulation was maintaining within a fluid resuscitation. The aim of physical monitoring is to giving an oxygen. Oxygen is the first drug we need to deliver it, and fluids needs to be given, and drugs we'll take up one by one. The moment you say oxygen therapy, all the patients with acute exacerbation of asthma, hypoxia, basically result of ventilatory perfusion mismatch is there. We need to give an oxygen. And we need to give a salbutamol nebulization. If you give a salbutamol nebulization without oxygen, that is likely to worsen the ventilatory perfusion mismatch, pulmonary vasodilatation of the lung, that causes a poorly ventilated thing. That's why when you are delivering a nebulization, we need to give it with an oxygen. What is the current recommendation for the mode of delivery of oxygen? Then will be when the moment we talk about the delivery of oxygen, is it a low flow and high flow? Nowadays, we are talking about HFNC with the background of a COVID-19. I'm sure everyone is aware about what is humidified high flow nasal oxygen. Let us take up one thing. If you are delivering oxygen with an high flow to maintain the saturation of more than 94%, this is a non-rebreathing mask where you can deliver up to 100% of an oxygen through the non-breathing. Remember one thing, if you're delivering to the non-rebreathing mask, we need to give a flow of oxygen should be 8 to 10 liters. HFNC. So HFNC, when you look at the HFNC data, when you retrospective studies which have showed the feasibility and safety of humidified high flow nasal cannula in the children with severe asthma, blood gas and clinical parameters will improve significantly. Need for mechanical ventilation will be low, will be less. And also the patients will improve very quickly. Coming to the fluids, so judicious use of IV fluid is the basic thing. Most of the asthmatics are dehydrated because of a poor oral intake and increased insensible fluid loss. SIDH may be the common in the severe asthma. Maintain the euvolemic state. Overhydration lead to the pulmonary edema. That is why we should always watchful on 1, sodium level, 2, on the volume status, 3, on overhydration that can cause a pulmonary edema. Let's look at the drugs and the route of administration. The moment we talk about the drugs, first thing which comes to your mind is salbutamol, bronchodilator. After oxygen, next thing is salbutamol nebulization. So what the latest GINA guidelines, in the case of a severe exacerbation, we need to go upfront with salbutamol and ipratropium combination in a severe exacerbation. So this is a continuous nebulization with oxygen is the key. When you look at the continuous and intermittent nebulization, continuous always plays better role. Even when you look at the studies, the prospective randomized study of a continuous versus intermittent nebulized salbutamol in status asthmatic children, basically continuous nebulization is superior to the intermittent nebulization. The more rapid clinical improvement is the key, more the patient friendly, more cost effective, reduces the duration of hospital stay. That is why continuous nebulization needs to be done. Coming to the steroid, mandatory for the treatment with steroid, you always go upfront with steroid. If the patient is able to take it orally, it is oral steroid. Since it is a severe, parenteral steroid is preferred in a critically ill children. Hydrocortisone and methylprednisolone, both are equally effective. When you're using hydrocortisone, you can go with a 4 milligram per kg, repeat once in 4 to 6 hours. What about methylprednisolone? Methylprednisolone is widely used in some of the intensive care unit because of a limited mineralocorticoid effect. So National Asthma Education and Prevention Program recommends that if you're using a methylprednisolone, use in the dose of 1 to 2 milligram per kg, maximum of 60 milligram per day in a 2 divided doses, you can give it. Coming back to the Ramesh, so this child of Ramesh is treated with an oxygen, appropriate fluid, salbutamol and ipratropium nebulization was started upfront, and hydrocortisone was started. So reassessment was done. Respiratory, in spite of these measurements, this Ramesh is increasing respiratory rate, saturation which was less than 80%, now still it is in a low, increased work of breathing, and X-ray, and also the chest auscultation, it was a silent chest. Ramesh condition is worsened. Next question comes, what are the options which is ruled out? Always when the patient is worsening in a case of an acute asthma, as a clinician, we need to rule out the condition that is mimicking asthma, that is the key. After that, you can look for some of the investigation like chest X-ray, because complication is one thing. Routinely chest X-ray is not required in acute severe asthma. If it is not required, that's the time. ABG, bronchoscopy, if you're suspecting mucus plug or foreign body, something like that, that's the situation where you think about bronchoscopy. Otherwise, in routine practice, it is no. X-ray, which is showing an hyperinflated lung field. Next thing comes, how do you manage this case? So acute exacerbation that does not respond to the conventional therapy, as a clinician, what are the options which is left? One is IV magnesium sulfate, terbutaline, which is not freely available across India. Yes, some centers it is available. Aminophylline, what we use it in our ICU, but I'll come to that. When do I use? Ketamine, yes, some of the patient we need to. These are the options which is left if the patient is worsening. Let's take up magnesium sulfate. The magnesium sulfate, it acts by smooth muscle relaxation by inhibition of calcium uptake. It is a bronchodilator. Magnesium sulfate is used in the dose of 50 milligram per kg. You can give it 0.1 ml per kg of 50% in IV infusion over a period of 30 minutes. And it can be repeated 4 to 6 hours, 3 to 4 doses can be given. But remember one thing, when you're using a magnesium sulfate, you should always be watchful on hemodynamics because it is likely to cause an hypotension. If the child develops hypotension, you give a small aliquot of a bolus of 5 to 10 ml per kg of crystalloids, it can be given. Coming to the terbutaline infusion, we used to use the terbutaline infusion 5 years back. Now terbutaline is not really available. We are not using, we are going upfront with the magnesium sulfate. If you're using terbutaline, it is 10 microgram per kg followed by 0.3 to 0.6 microgram per kg per minute. Increase by 0.2 microgram per kg per minute, maximum of 3 to 6 microgram. Prepare the terbutaline drip, add terbutaline drip of 0.6 milligram per kg in 50 ml of dextrose, and so that 1 ml per hour can be given with a 0.2 micro. This is how we can prepare the things. What about aminophylline? Aminophylline is then a old drug. We all used as for last 30 to 40 years, we are using aminophylline. But once where the terbutaline is not freely available, if a patient is not responding to the magnesium sulfate, that's the time where in our ICU, we do use an aminophylline. But remember one thing, it is in a low therapeutic index. It is likely to cause a tachyarrhythmia, hypotension, GI intolerance. We have to be very, very watchful. So it is a controversial in things with narrow therapeutic range, high risk of serious adverse effect. That's the reason if you're using what we use, it will start with a 5 milligram per kg, followed by 0.5 to 1 milligram per kg as an infusion. What about ketamine? Ketamine is an anesthetic drug. Yes, we do use it in intensive care unit with the direct bronchodilator effect. It is associated with bronchoria and excessive secretion. If you're using with the 0.5 to 0.7 milligram per kg per hour, it is not an issue. You can load with the 2 milligram, then followed by 0.5 to 2. But bronchoria and siluria is an issue. 1.5 hours after the admission, Ramesh was started with IV magnesium sulfate. Child very irritable and became drowsy. Oxygen requirement was increasing. Respiratory rate is decreased. Air entry was minimal bilaterally. Pulses paradoxus and ABG. Look at the ABG. pH is 7.156. PaO2 level is 67. PCO2 is build up is there and bicarbonate is 13. How do we proceed? Is there any role of mechanical ventilation? Let's look at these things. When do you use a mechanical ventilation in case of asthma? In my clinical practice of intensive care unit for last 20 years, I used it in a two times only in last 20 years. That also one of our residents who started in a mechanical ventilation. By the time we came in the morning, we have extubated the thing. Now, what I mean to say that need for mechanical ventilation in acute exacerbation asthma, if you follow the protocol, is not really required. That too with the use of an HFNC. So, which is associated with high morbidity and mortality. That's the reason we try to avoid it. Barotrauma due to the dynamic hyperinflation. That's the reason we need to avoid impaired venous return, that is tamponade, and low cardiac output due to the hyperinflation pulsus paradoxus. Main indications are clinical deterioration despite of maximal drug therapy, rising PCO2 level or low PaO2 level, fatigue, lethargy, deteriorating with the mental status, mixed respiratory and metabolic acidosis. That's the indications for mechanical ventilation, but very, very limited in the practice. So if you are intubating the child with an acute asthma, so what you need to do is rapid sequence intubation using a midazolam and ketamine and rocuronium can be used. This patient was intubated with a 6-cup thing and fixed at 16 centimeter. Ventilation strategy. If you are using ventilation, it is a minimize the strategy is to minimize the end expiratory volume, intrinsic PEEP and maximum expiratory time, and using a low tidal volume and respiratory rate with the permissive hypercapnia have been shown to be associated with a lower mortality in a case of an asthma ventilation. Ramesh is improved after 36 hours of ventilation and ketamine infusion, extubated, later shifted to ward. This is the one patient where I have been ventilated, but majority of the time it does not require a ventilation. When do you discharge an acute asthma patient? Discharge criteria will be: 1, if the patient is comfortable, feeding well, taking oral acceptance is good, sleeping well at the night, and not on IV infusion, receiving salbutamol less frequently in the 6 hours, and pulmonary score index is less than 3. That's the time where we need to discharge. COVID-19 and severe asthma, let's look at that, what the literature and GINA guidelines say. Early initiation of a short course of a steroid, oral or intravenous, as per the clinical condition, it is going to play an important role. Children may require long-term oral steroid along with inhaled medication, especially for instead of 3 days, you can give it for 5 days. Biological therapy should be used in severe asthma patient with a limited use of oral corticosteroid. Nebulization should be avoided in acute asthma because it is an aerosol generating procedure. Pressurized MDI is then handy, while being treated for a severe attack of maintenance of inhalation therapy should be continued. So what the carry home message is, O2 inhalation is the key in a patient with asthma. The drug of choice is O2 inhalation because there is a ventilatory perfusion mismatch. Upfront use an O2 inhalation. Judicious use of drugs like oxygen, judiciously we need to use. Oral salbutamol and ipratropium bromide, depending upon the severity, we need to go upfront. Continuous nebulization is the key with the bronchodilator. If the patient is not responding, you can, along with that, you can give an oral corticosteroid or parenteral steroid. If the patient is not responding, you can consider a magnesium sulfate. Be watchful when you're using a magnesium sulfate. Hypertension is the thing. Then comes your terbutaline if it is available, or you can use an aminophylline as a drug. And assess and reassess, look for the complication. Monitoring is the key in an acute asthma. That is what, as a clinician, we need to learn in the clinical profit. Avoid nebulization, avoid invasive ventilation, educate the patients and parents before the discharge, because that's the key message is very, very important. Thank you once again, the team Asthmacon, led by Dr. Atanu Badra and team, for organizing this wonderful. Thank you once again, giving me an opportunity to speak on this occasion. Thank you.
Thank you, sir. Thank you, Dr. Vasavaraja. Such extensive, along with those case presentation. Now, the next speaker I would like to invite is Dr. Pavan Kalyan. He is a professor of pediatrics in the PS Institute of Medical Sciences, Vijayawada. He is the secretary of IIP AP State, Andhra Pradesh, and he was also in the advisory National Advisory Board member of Indian Pediatrics 2020. He will be talking about biologicals in asthma. Yes. Hello. Yes, Dr. Pavan Kalyan, sir, please.
Yes,
You can
sir.
start
Thank you.
now.
Yeah, yeah. Thank you very much, sir. At the outset, I would thank the Kolkata Metropolis Academy of Pediatrics. But before saying anything further, this is to the pulmonologist, core pulmonologist who does for the biologists. It's only for the general pediatrician to understand there are certain medications where asthma can be still be treated. So as we go ahead, we will know what exactly is it. So my overview would be on introduction, various phenotypes of asthma, what are the indications and various biologicals, and what are the key home messages. Now, before going to something, let us understand where we going to use. So we'll take a case. Ram is a 9-year-old child who has been diagnosed as asthma at 7 years of age by the spirometry, where you have seen a reversibility, bronchodilator reversibility, and then he has been diagnosed asthma and has been started on preventer therapy, which includes your inhaled corticosteroid of budesonide of 200 micrograms, 2 puffs BD, and still is having intermittent exacerbations with this amount of dose, with the massive. And he was also added on long-acting beta-2 agonist, which also is a formoterol with the budesonide combination, and it has been continued. In spite of this, the child had more than 2 exacerbations, which were requiring oral corticosteroids, and the parents got fed up. This is going on? Still, my child is having recurrent exacerbations. Is this only asthma? Is something else? Is the first question to them. Or if this is an asthma, even though we have proved it by spirometry, is there any other things which could also help us? So this is the GINA 2020, where you have seen that budesonide, just to say that more than 400, this is for the DPI, but for also the MDI would be the same, is more than 400. So it is, the child was taking more and is in the high dose corticosteroids. Now this is the strategy which all of you have seen, that this is the 6 to 11 year age, because I have taken a case of 9 years old. That is the reason I have taken of a 6 to 11 years. Here we have finished step 1, step 2, step 3, step 4, which includes your medium dose ICS with LABA, and some you have referred for an expert, but you don't have that. When you don't have a pulmonologist here, where you have increased the dose and said, okay, this is the time where, okay, I have to send to a pulmonologist. Now what is left? Now you should understand, you will do a phenotypic assessment before we do something else, and whether you add on a therapy of a biologicals, whether anti-Ig, anti-IL-5 or anti-IL-4R, whatever we are going to talk in the next couple of slides. So this is again from the GINA 2019, the pocket good, where you have talked about the severity of the what you call the asthma. You have to phenotype the asthma. Just based on this, my talk is going to be there. So whether this is a type 2 inflammation. How do you know the child has a type 2 inflammation? By looking at the blood eosinophil count, by looking at the pheno, by looking at the sputum eosinophils. Is the asthma is an allergy driven or not? Need for the maintenance of oral corticosteroid, and based on it you need to investigate for comorbidities as we go ahead, and I'm not going to talk, because this is based on this we are going to talk about biologicals. So whether you want to give an add-on therapy of an anti-IgE, anti-IL-5 or anti-IL-4, I would be talking in the next couple of minutes. Now, childhood asthma is an heterogeneous disorder with multiple phenotypes, as we said. And you should know 95% of the cases would be treated by normally, only 5%. Like our NALS, NRP, 95% or everybody is a normal newborn, only 1% would be there. In the same way, the asthma, only the severe asthma is only 5%. For that 5%, we need not break our brain or head, so that you can refer to a pulmonologist who is get trained. But you need to know when to refer this patient, whether this child has gone out of order. So there are different clinical variants, that is phenotypes, which I am going to talk about, type 2 and predominantly high and low. So what is our main goal? Before you saying a severe asthma, the child has achieved a good asthma management, good control. Whether the child has reduced exacerbation, were we able to prevent the asthma related deaths? For achieving good control, you need to have you are giving inhaled corticosteroids, and sometimes you are adding one more control therapy. Would this inhaled corticosteroids really change anything else? What does it do is suppress the bronchial inflammation and restore airway hyperresponsiveness. but it is not going to be a disease modifying agent. So there should be something, because we want to cure it, because still we are in the era where we are only talking about the asthma can be controlled but not be cured. So we are not able to do where this is not working in severe asthma, sometimes we need to modify our therapy. And you know that you have to have a personalized treatment. The child which has responded to one treatment would not respond to the same, the other child would not respond to the same management. So you should have a personalized treatment for it. So how does severe asthma is been defined by the ATS, that is American Thoracic Society, and the European Respiratory Society, is that asthma requiring treatment with high dose of inhaled corticosteroid, which our candidate has fitted into, and also was on a second controller, which has been a LABA, with or without systemic corticosteroids for the control of disease. For the control of disease, if this is requiring, yes, then you should think that this is a case of severe asthma. Why are we worried? If the child has severe asthma, why should we get worried? Because if the child has a severe asthma, he may be having recurrent hospitalization. So there is a financial burden to the parents and would have a poor quality of life, because he would have been absenteeism, he would not be going to school, and he would be definitely have a failure to thrive. And he has an impaired lifestyle, he will be depressed. And not only that, when you keep on giving recurrent, because of acute exacerbation, you give an oral corticosteroid, there are certain detrimental side effects with the oral corticosteroids. Because even though it has been there in Western world, where I worked in Australia, we had seen a child who is 80 kgs, you cannot give the steroid each time to that 2 milligram per kg, the ceiling level. There are certain detrimental effects of oral corticosteroids. So who are the actual candidates? The child with uncontrolled or severe asthma are the candidates for your biologicals. So before that, you need to give, before giving a biologicals, what we have talked on add-on therapy, you need to understand the phenotyping and the endotype. So asthma phenotypes are related to the airway inflammatory pathways, that is the endotypes. So how they are determined by your numerous cell types, your eosinophils, basophils, mast cells, and the cytokine mediators and immune pathways. So the endotypes are based on the expressions of your cytokines, such as your IL-4, IL-5 and IL-13, which are secreted by your classical T helper cells too, such as your CD4 lymphocytes. There are non-classical immune cells that are called as innate lymphoid cell tissue type. That is the reason we are not talking as Th2 type of asthma, but we are talking as T2 type of asthma. So there are two inflammatory endotypes which we are going to talk about, type 2, which is, and non-type 2, or type 2 high and low. So the biologicals what we are talking about are targeted inflammatory modulators which play a key role in the pathogenesis of asthma, predominantly on the T2 high subset. The most of the severe asthmas, or what of the asthmas, are eosinophilic asthma, out of which half of them are T2 high subset. Now this is a picture which gives you a rough understanding. I know it is very difficult, but just concentrate that when your body, genetically susceptible asthmatic child, is being exposed to your allergens, viruses and irritants, what they cause to the airway epithelium, what it does is it stimulates your TSLP, the lymphocytic protein, and in turn it stimulates this TSLP, interleukin 33 and interleukin 25 are the major subsets, where it stimulates your IL-4, IL-13 and IL-5. If you see the approved drug target are IL-4, IL-5, it has been seen. In turn, this activates your eosinophils, basophil, mast cells, all degranulate to cause your symptoms. Not only that, it also stimulates your B cells to change to IgE cells, switching to IgE production. And not only that, it also does to your innate cells, causing your baseline bronchial enlargement, basement membrane thickening, goblet cell hypersecretion, mucus secretion. These all will be there, and your bronchoconstriction, which is your cause. So basically, when you have this, your TSLP, IL-33 and IL-25 are the things which stimulates your IL-4, IL-5 and IL-13. And these are one subset, and your IgE, where your B cells get, where your targeted therapy are there. So in the T2 endotype, you have high, which are allergic eosinophil asthma, where there are certain allergens which are being sensitized. Or you can have a non-allergen sensitized high eosinophilic asthma. Whereas in a low endotype, where your neutrophilic, your mixed or passive granulocytic, where your corticosteroid doesn't act, where you need to give a macrolide, that you would be knowing by doing a ball, or sometimes in spite of your oral corticosteroid, the child is not responding. We think as a neutrophilic asthma where your T1 cells get stimulated and your IL-17 pathway takes place. So when you know this is properly an a T2 receptor, what are the markers? How do you know this is a T2 sort of inflammation? You can do a sputum and a blood absolute eosinophil count. You would measure a serum IgE level, and wherever possible, you can do an exhaled nitric oxide. All centers do not have an exhaled nitric oxide, but you have a sputum and a blood absolute eosinophil counts can be measured, and you have a serum periostein, which is also not can measured here. So according to the ATS and ERS task force, what are the things which we think that this is severe asthma? As I said, asthma which is not been controlled by high dose inhaled corticosteroid, where you have a poor asthma control and you have more than 2 bursts of systemic corticosteroids or more than 3 days each in the previous year, serious exacerbation of greater than 1 hospitalizations or PI stay in the previous year, and airflow limitation of FE1 of less than 80% predicted following SABA and LABA withhold, then these are all the indications falling into severe asthma carotid, and you require your what you call your biologicals. When you patients refer, basically the child is referred with respiratory symptoms despite your high asthma therapy. Once you see such patients, kindly please note, I will tell you, 95% of the patients, our basics are not right. That is the reason we are labeling as a difficult to treat asthma or resistant asthma. So what you need to is revisit your history, where you may have a failure to thrive or a bronchiectasis or a foreign body, or sometimes your enlarged tubercular lymph node can also cause such type of cough. And you do a chest CT, you may find a bronchiectasis changes. When that is, you have seen with all this, you have taken a thorough focused history and you have diagnosed is not asthma and our diagnosis is wrong, we investigate and we manage it properly. But sometimes in spite of all these things, you might find that yes, there are something wrong. Then you should have a multidisciplinary treatment rather than a single phase person. So there are 3 types: severe therapy, which is resistant asthma, or a difficult asthma, or asthma plus comorbidities, or you can have an overlap of all the 3 categories. Now let us think about what you mean by difficult asthma. Difficult asthma is nothing but where your compliance is poor, the child is having an exercise-induced laryngeal obstruction, that is your vocal cord dysfunction, obesity. These are all the difficult asthmas where we think it is not because of the treatment, because of the comorbidities sometimes. The asthma plus could be of comorbidities again, like your rhinosinusitis, your obesity, these all will come. In spite of all this, if you are not able to get your proper asthma, then you treat them as severe therapy resistant asthma, where you need to investigate further by invasive methods, which we will talk about. That is, severe therapy resistant asthma is your considered bronchoscopic airway phenotyping, where you do a ball and you get it. Your sputum eosinophil, or whether it is eosinophilic predominant or neutrophilic predominant. Now, difficult asthma plus. What do you mean by difficult asthma plus? Is again, the child is obese and is difficult failing to lose weight. And you have an environmental exposure, tobacco exposure, all sorts of this. Now, previously they thought that if the parents are not following our instructions, why should we give biologicals? But this is in the Andrew Bush study, which they found that what they said, even though the parents are not following the treatment, why should a child suffer? So even though there are patients who are not following our instructions, if the child is suffering with very severe asthma or a difficult asthma, still you can consider your biologicals. Now we'll talk about the multi-treatment plan. If we have approved that whatever we talked in, if the child has improved, then we said yes, and it is no longer difficult asthma. Now you called as a refractory difficult asthma and refractory asthma plus. Again, I'm talking about refractory difficult asthma, is again the parents are not willing, the child is not willing to lose, and they are not adherent, they are not following regularly to the asthma clinics. That is all. You come into a refractory difficult asthma, whereas an asthma plus is your comorbidities which are not being treated, and the child is not. So where you need to have much more. So what do you mean by multidisciplinary assessment for severe therapy-resistant asthma? You need to have a symptom pattern. You need to have an asthma control test, and how many attacks are being there, how many times the prednisolone has been used, and how many unscheduled visits have been come, and what are the severity of the symptoms, whether it is the laryngeal obstruction, that exercise-induced laryngeal obstruction, or vocal cord dysfunction is the cause because of stress or anything, why it is presenting, what is his school presenting or absenteeism, and what is his impact of the school. In the Western world, they have an asthma dedicated, they train a nurse because they wanted to prevent the asthma prevented. We also need to formulate such things and send them to the school and see what are the atmosphere. And you need to look for the breathing pattern. Who will be, because we don't have a physiotherapist, we are the physiotherapist, we assess. And we ask them to, because in case of your, I had a video where the child has a wheezing, but the saturation was absolutely normal, he was stressed out, and the cold has stimulated that. That is an exercise-induced laryngeal obstruction. Till 18 years of age, he was not been able to diagnose. So you do a laryngoscopy during exercise, or you can do a bronchoscopy. Most important is the psychosocial factors because of single parent or low socioeconomic status, anxiety, depression, adolescent. These are all patients where you have a psychosocial factors. Physiology is a spirometry. When you are on a long acting, at least you should have a 12 hours of off. And for a short acting, 2 hours is fine. And you do a spirometry with a bronchodilator challenge, it should be more than 200 ml. Or FE1 of more than 12% after the post bronchodilator challenge. And most important is your allergic sensitization. It could be dust mites. There are only 4 allergens which you have to talk about is your pollens, seasonal pollens, dust mites which are present, and your cockroaches, derpy mite, and the fungi. Other than that, you need to do a skin prick test, or pets, and there are also such things which are allergic sensitization. Food allergens are not much for your asthmatics. For airway inflammation, they ask us to do a pheno, but pheno is much costly. There are only certain centers who does a pheno, where you can do an induced sputum for looking for an absolute eosinophil count in your, and you can see a peripheral blood eosinophil, but it has not been correlated. They are trying to make good studies so that it would be help us. And most important is your nicotine exposure, tobacco exposure, which we need to ask, not only tobacco, but also mosquito coils. These are the things which you need to, but in tobacco exposure, in the Western world, they do a urine cotinine, but we don't do, when we suspect we do. And the last important is our drug device and this thing, your medication adherence. You ask them to take with a spacer, but they take directly. Or they are used to DPI in an acute exacerbation, they don't have such amount of functional residual capacity. In spite of that, they only take DPI. Then you need to see that. And there are certain things, you have an electronic monitoring in the Western world, here we don't have, but at least we have a peak expiratory flow, who are a brittle asthmas who cannot identify them. So you need to teach everything for a multidisciplinary. When you come, you need to check for all this before you label them as severe treatment therapy or therapy resistant asthma. So as I said, when you have a severe therapy resistant asthma, what are the things you do as an invasive monitoring? Is this an ongoing inflammation which is going on? If it is it T21 or T11? That is an eosinophilic or a neutrophilic? Is it responding to your oral corticosteroids? Sorry, is it responding to your steroids or not? Or is there a disconnect between your symptoms and the inflammation? And is there a persistence of your airflow limitation? So what are the tests we do? Each time for the visit they come, we see for an assessment of current symptoms, and we do a spirometry before and after, SABA. We don't do a lung clearance index, but it is done in the Western world, how well. And pheno is also there because in a corticosteroid eosinophilic asthma, you can see there is an increase. And you can do an induced sputum eosinophils in each visit. When you don't have, these are non-invasive, you can do an invasive one, that is a fiber optic bronchoscopy, where you will do for a neutrophils or eosinophils. And when you give steroid, whether it is responding to it or not responding. And you assess the treatment to your steroids. This is what we looking for. Now, I am coming back to the difficult to treat asthma, where you wanted to do an add-on therapy. In spite, we have proven that this is a severe treatment resistant therapy asthma, and we want to give an add-on therapy in the form of anti-IgE or anti-IL-5 or anti-IL-4R. So the child has fitted into the criteria of ATS and ERS what we have talked about. When we want to give an anti-IgE treatment, you need to do it because it has to be allergen sensitized. Sometimes you may or may not. So sensitization of skin prick testing or specific IgB has to be looked at, and total serum IgV and weight gain within the dosage range. We calculate, we see when you give omalizumab, I will talk about, and what are the exacerbations in the last year. So what factors may predict the good asthma response to your anti-IgE is your blood eosinophils of more than 260, FeNO of more than 20 parts per million, and you have an allergen-driven symptoms like your cockroach is there and that acute exacerbation, and you have a childhood asthma. And as I said in the previous thing, once you have an IL-C21 or IL-33, it has been stimulating your IL-4, IL-5 and IL-13. So anti-IL-5 is again, they look into what are the things which you predict is your higher blood eosinophils, more exacerbation the previous year, and adult onset of asthma and nasal polyposis. Then you think of anti-IL-5 or anti-IL-5 receptor monoclonal antibodies. Anti-IL-4 is again, you see for a blood eosinophils of more than 150 and a FeNO of more than 25. And you are requiring your maintenance therapy of oral corticosteroid, then you think of anti-IL-4. This is based, when you come to a pulmonologist, we assess all this and we start. So what are the available monoclonal antibodies or biologicals in asthma as of today are only two. That is omalizumab and mepolizumab. Omalizumab is an anti-IgE. It binds to IgE receptor, which I will talk in the next slide. And now it is approved for ages above 6 years. They are trying to do studies in less than, there are ongoing trials which are going for less than 6 years also. Whereas your anti-IL-5 is a mepolizumab. The cost of omalizumab is 10,000. It is all, if you see in the Google network, it is there. And for a mepolizumab, 62,500 what they say. In the US criteria, they say that it is more than 12 years. And for in the European guidelines, it has come as less than, it is more than 6 years. It is being approved. Rasulimab is again an anti-IL-5 which binds to your anti-IL-5 receptor, and it is only used for more than 18 years of old. Benazimab is not available in India, anti-IL-5. This causes apoptosis of your eosinophils, basophils, and it is used in children more than 12 years of old. Dupilumab is an anti-IL-4R. This is the only one which binds to IL-4 receptor and blocks the signaling of both IL-4 and IL-13. And it is used in children with 12-year-old with severe eosinophilic asthma, which are unresponsive to what I am talking. Now this is the slide, very simple slide. Omalizumab anti-IgE more than 6 years. The dosing is 75 to 600 milligram, depending on, it is based on the age and also it is based on the IgE level. The IgE level for what they say is about 30 to 1500, and this is against your perennial allergens, and the FeNO should be more than 30 parts per billion. What are the side effects, or its back warning is that you have a headache, pharyngitis and injection site reactions. Is it efficacious? Yes, we don't know about the long term. There are number of, since last 10 years there have been studies which are going, there is a increased asthma exacerbation, there is an increase of FE1, and you have an increased quality of life, and there is a decreased inhaled corticosteroid dose and seasonal exacerbation. At this stage, if somebody asks for how long to give, there are no certain guidelines. But if the child is responding, then we give for at least 2 years and then try to see. The treatment at least we see for 2 months, and then if the child is responding, then we give for 2 years. Mepolizumab is an anti-IL-5. As I said, it's severe eosinophilic asthma. And for US, it is more than 12 years, but European, it is more than 6 years. So 100 milligrams subcutaneously, this is an all subcutaneous injections, 2 to 4 weeks or 4 weeks. It is the same. The blood eosinophil is based on your peripheral blood eosinophil count of more than 150 to 300, and the same hypersensitivity reactions. Rasulimab is the same because we only deal with omalizumab and mepolizumab. I am not talking about rasulimab. When the only one thing which I want to talk is depemokimab, is we don't have the peripheral, what you call a biomarker. So we need a biomarker, which drug to choose and how to go about. We are talking about so much of T2 asthma or high asthma. What about non-T2 asthma? Are there any biologicals? So as I said, anti-IL-25, which is an IL-25 is a T2 cell derived belonging to IL-17 family, which mediates your cell-mediated 2-Th2 response. Till date, there is no clinical trials for your anti-IL-25. Anti-IL-33, which I have talked about in your innate, this picture, if you can see back, yeah. IL-33 is the one, TSLP. These are all the three non-T2 type where you can also see, it also helps us. And you don't have, there are certain studies which are coming up. So there are under phase trials. 2 clinical trials are going on. Anti-thymic stripolipal antibodies, it also belongs to your IL-2 family. They are trying to evaluate. Anti-IL-17 and tumor necrosis alpha, which are for neutrophilic and for your basigranulocytic, there are no available clinical trials. The only 2 which we have as an anti-IL-33 and anti-thymic stromal lymphocyte, which activates again through T. So what are the key home messages? In 95% of the cases, and whatever they have studied, they have looked into the biologicals versus placebo. In those studies also what they found was that placebos was also responding well. That means it is not the biologicals or targeted therapy, but it is because of the adherence and the compliance that in 95% of the cases, you need to look for our basics, whether the basics are right or not. So that is the most important thing. And pediatric severe treatment resistant asthma is often eosinophilic, but frequently we don't have any inflammation, we don't have any evidence for Th2 pathway. The presently approved drugs to remember is omalizumab and mepolizumab. And what are the uncertainties we have? We don't have the optimal treatment duration. What are the long-term effects? And there are more gaps in non-T2-1. We don't have any drugs as such. Some of them said hypothesis that why only one drug? Because it is not acting good. Try a cocktail of anti-IL-4 and anti-IL-6, anti-IgE therapy. So there are certain theories which have been going for the betterment of the child. Now, if you have diagnosed as a patient with true severe asthma, then the luminal obstruction, either it is mediated by eosinophils and you have an allergic sensitization, go with your IgE mediated therapy. When you have a luminal obstruction mediated by eosinophils, then you think of anti-IL-5 monoclonal antibodies like your mepolizumab are the choice. Luminal obstruction by mucus production, eosinophils and smooth muscle contraction and remodeling, that is your dupilumab, which is not available in India, and it is also US in more than 12 years, and you have an atopic dermatitis, and we don't have a biomarker for such. So with this, I hope I have not confused, but one thing is that 95% of the patients, you need not get worried. It's only our history, and we look into the compliance of the patient would help us in treating the asthmas. Only 5% really do require, and where you can refer, put an arrow, refer to a pulmonologist. And thank you for your patient hearing. If any doubts, I would like to take.
Thank you very much, sir. It's a beautiful presentation.
Sopan sir, I think there was an internet issue.
There was possibly he got mesmerized by Pawan's lecture.
Yes.
Now he has come from the trance. Come on.
No, sir, I made him sleepy.
Now,
Shitapal, continue.
Yes. Dr. Raj Tilak is a very senior pediatrician in Kanpur, and he is fellow of pulmonology, PGI Chandigarh. He was a former member, faculty member of GSVM Medical College, and he is a prolific author also. He has put up 10 publications in Lancet Respiratory Medicine and textbook of practical pediatric pulmonology, and he is also a trainer in asthma training module. Sir, yes, Dr. Raj Tilak. Sir, please start.
Thank you very much, Dr. Ratangiri. And I am really impressed after listening to Pavan. For such a difficult lecture could not have been delivered by anyone else other than Pavan. My compliments to you. Well, Dr. Ratangiri has assigned me the task of speaking on Asthma Plus. So now I am going beyond asthma to talk to you about Asthma Plus. Asthma is not a singular disease or a disease of isolation, but a tree of a family of similar issues in other organ systems and the consequences that follow, like allergic rhinitis, like adenoidal hypertrophy, like eustachian tube dysfunction, like otitis media with effusion, like allergic conjunctivitis, like sinusitis, nasal polyposis, gastroesophageal reflux disease, which works in quite close conjunction with asthma, more propensity to have viral infection, and allergic laryngitis. So it's a pedigree that we need to understand while dealing with whatsoever is beyond asthma and is called asthma plus. Although, of course, there is a genetic basis to development of asthma, and therefore we find that in families there are sequences of greater probability of suffering in the children thereof. But the nature is nurtured under environmental influences. Allergic diseases are generally believed to be caused by disturbance between Th1 and Th2 set of cytokine profile pathways. In fact, to be more clear, it is persistence of the Th2 cytokine profile which was earlier present in the womb, which does not alter and continue to remain same despite the life that comes into existence outside the womb. The allergy speaks in plural languages, and all these conditions are part of a larger systemic inflammatory syndrome. The signs and symptoms of these syndromes may be vary depending upon which organ is principally involved. The key message is that the allergy speaks in plural languages. Allergy can affect different children in different ways. There is a concept of understanding which is called atopic or allergic march. This is in fact the sequence of allergic events which switch from one clinical expression of allergy to another in progressive stages of life. The eczema is first to peak and then peaks subsequently food allergy. Then there comes the puking of asthma, and allergic rhinitis is last to peak. But you see, all of them are stemming from a common junctional point, and that is persistence of the Th2 type of cytokine pathway. But this is only a hypothesis and not always true. The first thing according to the hypothesis is atopic dermatitis, which frequently heralds the atopic diathesis. But as I said, this is not always true. The sequence may also change. In 7,662 patients who visited the physicians, 17% allergic rhinitis patients were found also to have asthma symptoms. And when they were further classified, it was seen that in about 25%, rhinitis and asthma appeared simultaneously, while in 35% of them, asthma appeared first, and in about 40%, allergic rhinitis was first to appear. So this sequence can also alter and is not a script written on the stone. Now let us see what are the comorbidities of asthma, whether allergic or non-allergic. There are about 10 to 40% patients of allergic rhinitis have asthma, while approximately 80% of the patients with asthma have accompanying symptoms of allergic rhinitis. And up to 60% of the patients with asthma have sinusitis also. There is a concept of what we call as united airway disease, or popularly called as one airway, one disease. Asthma and rhinitis are not two sides of the same coin. They are one. Uncontrolled allergic rhinitis may lead to worsening of coexisting asthma, while treating it helps in its controlling asthma symptoms, in improving bronchial hyperreactivity, and improving the lung functions. Asthma patients with or without rhinitis symptoms also have elevated eosinophils in the nasal mucosa compared with the controls. Patients of allergic rhinitis were 3 times more likely to subsequent development of asthma. That is to say, rarely does one hear wheeze without a sneeze. And therefore I say that all these comorbid conditions must be studied as a cluster disease. If you find one, the search for all others must be taken, and screening all patients who present with asthma symptoms to rule out rhinitis and other comorbid conditions is imminent and impending upon the consultant. Treating sneeze can adequately will reduce the wheeze also. Now, coming on to introduction of allergic rhinitis with its clinical presentation. While identifying allergic rhinitis, there are certain cardinal presentations, out of which the important ones are nasal itching. You can find people doing like this time and again because of this itch, knowingly or unknowingly. They have paroxysmal sneezing. Patient come to you saying that they have a sequential repeated sneezing every day in the morning, or when they visit bathroom, or when they get up, or when they visit some particular place, then they can be of two types. Either they can be runners or they can be blockers. That means they can have a running nose or they can have a blocked nose. If they are runners, the nose can drip anteriorly or it may even drip posteriorly from the posterior nares. And if it drips like that, the post-nasal drip would lead to chronic throat cleaning cough. Like this. The posterior nasal drip and throat cleaning cough is more frequent when you change your posture from orthostatic to lying down. And it starts almost immediately before going to sleep. Because all the secretions that were present in the nasal cavity then start dripping at the back of your pharynx. Then there can be another situation where congestion becomes predominant feature and you turn from a runner to a blocker. And therefore it becomes difficult for you to breathe from nose. Such people, you would find that they start breathing with open mouth and with frequent snoring. By breathing from mouth, they also produce lot of negative pressure in the nose from where they are not able to breathe. And such people, therefore, if it starts from childhood, would also have a high arched palate. Because of breathing from mouth, they would find a coated furred tongue also. Then we must look for signs of allergic rhinitis in every case of asthma, like allergic shyness. That means that they have dark circles around their eyes. They have Dennis-Morgan lines, meaning thereby they have prominent crease below their lower eyelid. They have nasal crease on the nose at the junction of the hard nose with the cartilaginous nose. This is allergic crease, because many a times they do maneuvering like this, and it is at this juncture that by repeated bending, this type of line gradually develops, called nasal crease. And this type of mannerism is what is called as allergic salute. Then, if you examine their nasal mucosa, you would find that because of edema, it becomes pale. Post-nasal drip is a conspicuous finding on change of posture, even otherwise sometimes. They also do have cobblestone pharynx. If we see to their pharynx, pharyngeal wall at the posterior end, we find it a very lumpy, bumpy structure, as if a carpet might have been spread over enlarged lymph nodes, which mimic like cobblestones. So such lumpy, bumpy posterior pharyngeal wall tells you that because of the allergic inflammation of the nose, sinuses, and other adjoining areas, you have lymphoid enlargement in the nose and at the back of the posterior pharyngeal wall, giving it a cobblestone pharynx appearance. Then you can also have allergic conjunctivitis in association with allergic rhinitis, because a similar type of inflammation spreads to the adjoining organs. And mind you, Gina says that in most cases of asthma, allergic rhinitis is present. And in cases of moderate persistent asthma, in about 97% of them, you have allergic rhinitis as a constant associate, a co-passenger. There is a stepwise management of allergic rhinitis, which starts from the bottom by avoidance of triggers, then addition of antihistaminics, not to say that they must be non-sedating and second generation, either oral or intranasal. If it does not control by these two things, then intranasal steroid spray becomes the medication of choice. And if the problem, despite intranasal steroid, does not come to control, then you can add all the three steps together. That means avoid triggers, use oral or intranasal antihistaminics, and use intranasal steroid sprays, and that becomes step 4. If even on step 4 things don't control, you can add nasal saline irrigation. Besides all the measures which you might have taken up to step 4. Most cases of allergic rhinitis would come under control until this step. But if they don't, you can consider them as special cases, and depending upon their need, you can add a chemical moiety. If rhinorrhea is the predominant symptom, you can add a pratropium bromide to it. If allergic rhinitis is with asthma, then leukotriene receptor antagonist becomes the molecule of choice for addition. And if there is additional allergic conjunctivitis, then antihistaminic eye drops can be added. You can add 1, 2, or even 3 as the need demands. But if despite all this, step 1, 2, 3, 4, 5, and 6, if situation still is uncontrolled, then you must understand that the case must be referred for specialist care to an allergist. We must go for allergen immunotherapy or omalizumab if associated also with severe asthma. Now, coming on to the sinusitis, which is almost always present as a part of rhinitis. Most of the time, if not. If sinusitis is for less than 12 weeks and we find complete resolution, then we consider it acute sinusitis. But in most cases of allergy, what you find along with allergic rhinitis is a duration of more than 12 weeks without complete resolution, and that puts it in the category of chronic rhinosinusitis. This can be either with nasal polyps or without nasal polyps. Polyps are present in about 4% cases. And these 4% cases, which also has nasal polyps, are associated with severe asthma episodes. And that must be kept in mind if asthma is with rhinosinusitis and with nasal polyps, which are present in about 4% cases, then you must expect that the control of asthma would be at a higher level where severe asthma needs its control. You also find that the turbinate, especially the inferior turbinate, becomes hypertrophied. Why? Because when you inhale, the allergens first enter through the nose, goes and strikes with the inferior turbinate. And thereafter, process of filtration gradually becomes less and less as it enters in. Therefore, the greatest impact of the allergy process comes on inferior turbinate. It may become a giant inferior turbinate. It needs to be differentiated with a nasal polyp. This is nasal polyp. Nasal polyp is usually grayish and is not attached laterally, while inferior turbinate hypertrophy, which is also called as bulla concha, is pink, is sensitive, while nasal polyp would be insensitive to touch, and this is attached laterally. I have already mentioned that you would find hypertrophy of the lymphoid tissue in such situations because allergens alter the immunology of the adenoid tissues. Broadly speaking, the allergic rhinitis and adenoid hypertrophy has similar symptoms, and the mode of management of the two also remains almost common. And this I am mentioning because Gina says that in most cases of asthma, allergic rhinitis would be compulsorily present. And when allergic rhinitis would be present, the whole family of co-passengers would also come in all cases of asthma. So whenever you find any one of them from this pedigree of Th2 type of manifestation, you must search for all others. Then there can be edema of the nose. The edema of the nose would also lead to edema of the eustachian tube, leading to its dysfunction. And because of eustachian tube dysfunction, you can find otitis media with effusion. Not only that, because of nasal obstruction, because of adenoids, because of congestion, because of nasal edema, because of polyps, because of turbinate hypertrophy, you find difficulty in breathing from nose, and such people also start snoring from nose. Asthma and allergic rhinitis are chronic diseases with recurrent symptoms impacting child's sleep, child's concentration, his development, his play, his exercise, his learning, and ultimately the self-image and self-esteem of the child. We see that an essential goal of all pediatric healthcare is to ensure normal growth and development. You see, about 78% of those who suffer from these disorders lack a good night's sleep. About 75% are unable to go to sleep. And about 64% wake up during night. Then we must understand that there is a concept of what we call as atopic triad. This is a triad of allergic dermatitis, asthma, and allergic rhinitis, or called as hay fever. You can have an assembly of these two. You can have assembly of hay fever and allergic dermatitis. You can have an assembly of allergic dermatitis and asthma, or you can have all the three together. Therefore, if you find, because this is the earliest manifestation of allergic march, 70% of the patients with severe allergic dermatitis develop asthma, compared with 30% of patients with mild allergic dermatitis and approximately 8% of general population. So you find, in comparison to general population, even patients of mild allergic dermatitis are approximately 4 times more prone. And they are about 9 times more prone if they have severe allergic dermatitis during their early childhood. So, presence of allergic dermatitis may be a predictor of the future course of action, wherein presence of asthma and allergic rhinitis may be coming in later days. Then gastroesophageal reflux is also a comorbid condition. Gastroesophageal reflux is more common in patients with asthma. However, it is never a cause for uncontrolled asthma. Many times, oral medicines like short-acting beta-2 agonist given orally and theophylline, when used, relax lower esophageal sphincter, and that adds insult to this injury. The symptoms of gastroesophageal reflux would be presence of heartburn, epigastric or chest pain, and nocturnal dry cough followed by vomiting. To treat this condition, which must definitely be treated if it is symptomatic, you can use proton pump inhibitors and motility agents, besides lifestyle changes. And if problem is serious, then fundoplication can be done. This needs to be investigated if therapeutic trial of PPI and motility agent fail, because that must be the first thing to be used if you suspect that gastroesophageal reflux is a co-associate and is also the cause of cough. Although, of course, as I said, gastroesophageal reflux is never a cause for uncontrolled asthma. In that situation, a 24-hour pH monitoring or endoscopy may also be undertaken. Then another comorbidity of asthma is obesity. Patients with asthma find difficult to express themselves if it remains uncontrolled in outdoor games, because they also have exercise-induced symptoms. So they develop their interest in indoor games, in TV watching, in mobile games, and do not exert much, which indirectly promotes obesity. And once obesity develops, that further compounds the insult over injury. Asthma, even otherwise, is more common in obese than in non-obese patient. It is also difficult to control in obese patients because the nature of inflammation is different. If you see this diagram on which on one axis eosinophilic inflammation have been expressed and on the other axis the symptoms are expressed, there are diseases where inflammation and symptoms are concordant. They are phenotypes of asthma. But then there are categories where symptoms are more, but inflammation is less. And there are categories which are discordant, where inflammation is more, but symptoms are less. Obesity comes in this category, where inflammation is far less, eosinophilic inflammation, but symptoms are far more. And therefore, by increasing the anti-inflammatory medicine, by advancing on anti-inflammatory dose, you would not be able to control the symptoms. Besides, there are several comorbidities of obesity also, like GERD, like oral corticosteroid, which further add to your obesity. Then there are mechanical factors, lack of fitness of obese people, and their reduced vital capacity due to their abdominal fat again add to this problem. If the problem of uncontrolled asthma is obesity, then you need to obesity besides the methods that you would employ to control asthma. Although, of course, you would use ICS and that remains the mainstay of treatment. But as I said, by increasing the dose, you cannot invite more and more effective control. Therefore, weight reduction is a must, and that can only help you improve asthma control, lung functions, health status, and can bring down the need for medication. We also understand that Th2 type of inflammation is like a yin-yang relationship, like a seesaw relationship. When one goes up, the other ends go down. So in all patients which have Th2 type of cytokine profile and eosinophilic preponderance for such inflammation have inferior Th1, that means infection handling abilities. All such people who have this type of inflammation are predisposed to more frequent and severe acute respiratory infections. Further, it induces expression of adhesion molecules like ICAM1 and VCAM, which are principal receptors of the rhinovirus. And we know that human rhinovirus type 1 is one of the commonest causes of virus-induced flare-up of asthma. Then Dr. Pavan Kalyan has very rightly said that Th2 inflammation also invite interleukin 13's involvement. And interleukin 13 is one that slows down the mucociliary clearance, resulting in viral invasion of mucosa, increasing the tissue susceptibility to infection. This thickens the mucus. Therefore, we must always remain vigilant once we have diagnosed somebody to be a patient of asthma, that he is also in for more and frequent viral infections with poorer viral infection handling ability. Like all other chronic illnesses, asthma does not have an exception. Patients of asthma, and more so if asthma is severe or remains uncontrolled, anxiety and an uncontrolled anxiety leading to depression is in for trouble. Such patients are more in patients with asthma. But we should not forget that even panic attacks may sometimes mimic as if acute flare-up of asthma, and that need to be differentiated. What is actual asthma and what is pseudo-asthma? For treatment of anxiety and depression, we can employ cognitive behavior therapy, psychoeducation, relaxation and biofeedback by help of our psychologist friends, clinical psychologists. Well, drug treatment can also be employed, wherein drugs used for depression have been found to give dividends in better control of asthma. However, drugs for use of anxiety give us a plus-minus response. We have not yet arrived at a conclusion that anxiety drugs really help in betterment of the management of asthma conditions. With this, the last entity on my slides is a common factor which can also be a part of the entire asthma spectrum diseases. The comorbid conditions, the associate of asthma, and it is food allergy and anaphylaxis. Although, of course, it is found in only less than 2% people, and this is more common is Western world than in Indian population. But then there would be someone who would have this, and we cannot dare to forget the importance of its identification. Food allergy patients have four-fold increased likelihood of having asthma. And sufferers of food allergy are susceptible for severe and even fatal reactions. However, I would like to warn that for diagnosis of food allergy, it is not only in vivo or in vitro. Actually, a food challenge must also be done to demonstrate that food is really responsible for flare-up of asthma. Because food-borne flare-up of asthma many a times is a part of an anaphylaxis syndrome. With all preparedness while doing this food challenge, because you may detect IgE, specific IgE antibodies in the serum, but may not find any food allergy, may find presence of food allergen positive skin prick test. But then when you actually do this food challenge, you may not find it. To say that somebody is allergic to food, you must have a panel of all the three and only then proclaim. And once you have identified there is greater propensity of asthma, its flare-up and anaphylaxis. For management of such conditions, appropriate food avoidance is inferior to none and therefore is strongly advocated. All such people must carry with them epinephrine auto-injector at all the time. While epinephrine auto-injector is not available in India, the adrenaline injection without dilution can be filled in a 1 ml syringe and can be kept in a spectacle box and always carried. And on a smallest suspicion of that somebody having food allergy going into anaphylaxis, the person must immediately inject it on the anterolateral side of the mid-thigh. And for this, we must train him. He is not supposed to remove his trousers and do it right then. Because earlier you use anaphylaxis stopping medicines like adrenaline or epinephrine, better is the outcome. However, the patient must also be trained in understanding the difference between asthma and anaphylaxis. And besides this, the regular reviews from time to time of such patient need to be solicited. With this, I thank you very much and invite any question, if any. Thank you.
Thank you very much, sir, for this enlightening speech, from leading us from sneeze to wheeze and all that, and ending in anaphylaxis. Thank you very much, sir. And now I invite Dr. Indranil Haldar. He is professor and head of pulmonary medicine, Kalyani Medical College, West Bengal, and he is also a diploma holder in European Respiratory Medicine, faculty of National Asthma and Bronchitis Institute, Kolkata, and he is also the zonal chairman of Chest Society and chairman of the state chapter of Indian Chest Society, 21 to 23. Dr. Haldar.
So, am I audible? Hoping I'm audible. Okay.
Right.
Okay.
Very well.
Thank you. In the onset, I should thank the organizing committee of the Asthmacon, and special thanks to the Metropolis branch, Kolkata Metropolis branch. So in fact, the topic given to me is something which I do practice, and it's from my heart, that is spirometry and pheno. And the time allotted being too short for a topic like a spirometry, where we are doing regular workshop on spirometry for 2 days continuously, and pheno also. So what I will do in the next 20 minutes is to be rather brief, just an overview of what spirometry and what pheno is, and how we utilize this tool for diagnosing and managing patients, pediatric patients. So in fact, before I start this thing on, sorry, there are two synonymous terms, the pulmonary function testing and spirometry. Pulmonary function testing and spirometry are not synonymous. In fact, pulmonary function testing includes a whole lot of things, which includes test of ventilation, test of diffusion, ventilation perfusion, exercise testing, and so on and so forth, including test of respiratory function. However, spirometry is the most basic and the widely used method for evaluating the pulmonary functions. So coming to why spirometry, it is basically useful for evaluating of cases with respiratory symptom, that is for a child who is having cough, wheeze, shortness of breath. It also is used for assessment of the severity of the respiratory disorders into the broad classification of mild, moderate, severe, or very severe. It also helps in the assessment of response to therapy, sometimes in preoperative pulmonary evaluations, mainly in elder children or in adults, and in sometimes in spatial functional abnormalities in predisposed individuals, in adults in occupational exposure, children's neuromuscular, chest disease, and upper airway disorders, where it is used for picking up restrictive and the severity of the restrictive disease. So what is spirometry? So if I am to speak about spirometry in just one sentence, I will tell it's a simple test to measure the amount of air a person can breathe out and the time taken to do so. So it's the force vital capacity maneuver. The person takes in full air, the person exhales the full air. We measure how much air is exhaled and the time taken to do so. Basically, it's also a device used to measure how effectively and how quickly the lungs can be emptied and filled. In nutshell, it is basically doing these two things. So ultimately, spirometry is a test for air flow. Clinically, it detects obstructive lung disease, which we are more concerned by measuring dynamic flow rates. And it sees whether obstruction is present or not. Not only that, it also sees whether obstruction is in the inspiratory, expiratory, or both. As told, it records the degree of obstruction and quantifies the stage of the disease within its broad limit of mild, moderate, severe, and very severe. So how is it done? It measures many maneuvers. Of all those, the force vital capacity maneuver is the most important that we do. Here, this child, in fact, it is usually measured in children more than 5 years or 6 years who can be trained. The subject in the first phase inhales maximum as much as of air he or she can, then gives a blast, and then keep on going, which the technician usually tells the child to do, going, keep going, keep going, keep going, keep going, keep going, keep going, and then another full inspiration to complete the whole cycle. So once this spirometry force vital capacity maneuver is done, we get some spirometric measurements. The measurements are recorded or represented in two forms. One, the absolute values are being done, and that's the software of the spirometry that is done. And one, we get some graphical loops. So what to look? The first thing when we do a spirometric maneuver is to look at the loop. And what are the loops we'll discuss. And then once the loop has been observed and analyzed, we look into the absolute values. In fact, most of this spirometry, we have about 32 or more absolute values that are given. But for all practical purpose, for interpretation of this spirometry, what is required is the FVC or the force vital capacity, the FEV1 or the force expiratory volume in the first second, the ratio which the software usually does it for us, the ratio between the FEV1 and the FVC, and another parameter that sometimes we look into is the peak expiratory flow rate. There are other parameters like the exhalation time, the AFEF 2575 and AFEF 7500, and all those in fact are required for some research purpose or some other special purpose which is not and which is beyond the scope of discussion. Now let us look into the graphical tracing. The two graphical tracing, the flow volume and the volume time curve, are generated in most of the spirometry. And in fact, to be a good spirometer, that should be the flow volume and the volume time curve should be revealed while doing the spirometry. And the shape of the curve helps us in identifying whether the subject has given adequate effort, knowing fully well that spirometry is an effort-dependent test, and whether the subject has done the test in the proper way can be assessed. And not only that, there is a quality control can be assessed. Not only that, by that, looking at the curve, we can assess whether obstruction is there, whether restriction is there, or whether and also grade the severity and the of the obstruction or the restriction. So just see what the flow volume looks like, whereas this is the flow in this axis and the volume, and the flow is plotted against volume to display a continuous loop from expiratory cycle, and this being the peak expiration, and the subject exhale, 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 and this one is the inhalation phase. So it's basically a triangle over a semicircle. Not going in details why the expiration is a triangle and the inspiration is a semicircle, but this is what it looks like. And this is the volume time curve, the volume on this axis and the time recorded in this axis. It is basically the volume of air that is exhaled, and ultimately the full volume of air is measured by the as known as the vital capacity, and the amount of air that is exhaled in the first second. This is the axis where the second axis is measured, where we have to measure the FEV1. So if anyone has to manually calculate the FEV1, so in 1 second, the amount of air exhaled can be measured from this curve. So now coming to the most important aspect of interpretation of the result of spirometry. So what do we expect from a spirometry? Either it is a normal, or it is an obstruction, which is reversible or not that reversible, or it is restrictive. These are the 5 things that we may get while doing a spirometry. So let us see what we do. So as already discussed, we should look into the force vital capacity, which is measured in liters, and it is the largest amount of air which can be delivered by forceful maximum expiration after a full inspiration. That is full inspiration, that is full expiration, exhalation to residual volume. And what is the FEV1? It is the volume exhaled in the first second of the forced expiration after full inspiration. And as expected, the narrower the airways, the smaller the airways, the FEV1 will be less. So that is directly proportional to the obstruction. So ultimately, it's a surrogate marker of the obstructive disease. And normally it should be more than 80% of the FVC. So now looking at or inspecting the volume time curve, you can see normal volume time curves looks in this way. So as we move on from the severity of obstruction, the curve shifts towards the right. You see, as we move into the moderate to severe and more severe, very severe, the curve just squeezes towards the right. Coming to the flow volume loop, as I told, it's a normal triangle over a semicircle. And looking at this curve, we can at least assess whether the person has given his full effort. The repeatability and the acceptability is to be seen. And again, by inspecting the flow volume loop, we can see whether obstruction is present from normal to mild, moderate, severe, and very severe, which is called the dog leg pattern. So by just inspecting the loop, we can assess how severe the obstruction is. Now, ultimately, not only from the lobes, but from the absolute value, we have to assess whether we are dealing with a normal, obstructive, restrictive, or a reversible obstructive that is reversible. So what is the thing that we have to look for? The first and the foremost thing that we have to look for is the ratio of FEV1 by FVC. If it is normal, then either we are dealing with a spirometry which is normal or reduced or restrictive. So who will tell us whether this we are dealing with a restrictive pattern? It is the FVC. If the FVC is less, that is less than the lower limit of normal, that is 80% for most of the cases, then we'll think that the subject or the person, the pattern that we are seeing in the spirometry is a restrictive lung disease, which has to be interpreted and correlated clinically, because restrictive lung disease can also happen if the subject is giving poor effort or not exhaling to the particular fixed time that he or she should exhale. Now, what is the FEV1 by FVC normal? As I told, it is the lower limit of normal, but sometimes it is very difficult for us to take the lower limit of normal. So what is available is we should see some fixed cutoff so that it is helpful or it is easier for us to assess. In most of the children, the cutoff abnormality of FEV1 by FVC should be taken as less than 90%. That is, if it is less than 90%, we should think that there is some form of obstruction. Adults below 40, we can take less than 75, which is there also in some of the most of the guidelines. But in children, it should be taken as less than 90%. So if the FEV1 by FVC is reduced, lower limit on normal or the fixed cutoff, then we have to see the FVC also. If in most cases, if the FVC is preserved or FVC is normal, we are dealing with a obstructive lung disease. And in most cases in pediatrics, the obstructive lung disease means we are dealing with a patient or child who is having asthma. If both of these are reduced, that is the FEV1 and the FEV1 by FVC ratio is reduced, and also the forced vital capacity is reduced, that means we are dealing with a child who is having mixed effect or severe obstruction where there is air trapping and the FVC has decreased. Once we get a obstructive lung disease, we should move on to do the spirometry after bronchodilator reversibility, which usually is by giving 200 to 400 micrograms of salbutamol, waiting for 15 to 20 minutes, repeating the test. And if there is an improvement in the FEV1 of more than 12% and 200 mils, then we can think that the subject is having good bronchodilator reversibility, which coincides with asthma, or if not, then the subject is having fixed airflow limitation, which usually happens in long-standing persistent asthma. So this is in a nutshell what I think we should or have an overview about this spirometry. Now coming to another diagnostic modality, which is now available in many of the centers, is the FeNO, as commonly known, or the fraction exhale nitric oxide, if we expand the term of FeNO. So what is this? That is FeNO, fraction exhale nitric oxide, is a marker of endogenous inflammation, which can be used to monitor inflammatory changes in the airflow. So what we know about asthma, the sine qua non in the pathogenesis of asthma is airway inflammation. It is basically an eosinophilic inflammation. And this is one of the biomarkers of airway inflammation. Why FeNO is so now accepted right now, only in pediatrics? Because it is simple, it is reproducible, and definitely a non-invasive way detecting the markers of inflammation, which is used as one piece of data to help a clinician better assess the patient's true underlying pulmonary disorders and potential changes in the treatment plan. So this is what we think of when we are dealing with a FeNO. So why nitric oxide? because it is produced by the human lungs and is present in the exhaled breath. It has been implicated in the pathophysiology of lung disease, including asthma, and has been standardized for many clinical use that we see, and the standard data can be available. So how is this done? You can see this simple instrument. There are different types of instrument, not going in details of that. Basically, it measures the level of the NO in the exhaled breath. It is usually done with a handheld device into which the patient blows. So the result is provided very fast and within 1 minute, and the cutoff values are there. So in children, the cutoff value, which I'll come, and most of the guidelines are there to tell us, it is usually more than 35 parts per billion, and in adults, it is usually more than 40. So what the ATS, American Thoracic Society document, tells us about the cutoff value. So in children, if it is 20 ppb, it indicates that the eosinophil inflammation and responsiveness to corticosteroid are less likely. So as already highlighted, asthma being a disease of inflammation, mostly eosinophilic inflammation. So if the FeNO is less than 20 ppb in children, that means it is less likely that inflammation is going on, particularly eosinophilic inflammation. And that means this is a subject where the steroid may not work properly. So a high FeNO, 35, more than 35 in children, let us concentrate more on children, indicates that eosinophilic inflammation is there. And if the subject is symptomatic, for example, if the subject is having cough, wheeze, or some form of shortness of breath, the subject may be responsive to corticosteroid, and we have to start corticosteroid or increase the dose of corticosteroid as may be indicated. So if it is intermittent between that, so between 20 to 35, it should be interpreted cautiously and with reference to clinical context. Persistently high FeNO means more than 35 ppb in children, and that is those who are having persistent eosinophilic inflammation. So what is the use of FeNO? In fact, I can tell you a list where it is used, assess the etiology of the respiratory symptom, whether inflammation is present or not, definitely to identify eosinophilic asthma phenotype, because again, when it comes to biologics, use of biologics, that will be very essential, which has already been discussed, because there are target which targets the eosinophil, and unless there is eosinophilic inflammation, there is no need of using that biologics. In potential response or failure to response to ICS may be seen to establish the baseline FeNO during clinical stability for subsequent monitoring. It helps us to guide change in the dose of anti-inflammatory medication, that is either we can step down if there is a decrease in the FeNO, or step up if the FeNO is increasing, and also adherence to the anti-inflammatory medication. But basically, it used in diagnosis and in the treatment of asthma. So ultimately, to assess whether airway inflammation is contributing to poor asthma control, particularly in the presence of other contributors. So the real question is, can it be used to diagnose asthma? The simple answer to this, what I have found out from most of the guidelines, is that though it has been often claimed that FeNO is a diagnostic test, but in cases of asthma, not due to airway eosinophilia, it may be low. So sometimes asthma inflammation may not be due to eosinophilic inflammation. In that case, though the subject is having asthma, but FeNO will be persistently low. Similarly, the value of exhaled FeNO as a predictor of steroid responsiveness is high, even in the absence of induced putative eosinophil. So coming to use of FeNO in pediatric population, since it shows evidence of bronchial inflammation and eosinophilic inflammation has been found in children prior to the diagnosis of asthma, which makes FeNO monitoring useful in early life to find out whether the child is having a propensity to develop asthma or not. And in infants and preschool children who are known to have more viral associated wheezing, it may be helpful to distinguish a phenotype of wheeze which may not be or may be controlled with inhaled corticosteroid. As told, that since FeNO picks up eosinophilic inflammation, and it definitely tells us who are the children who may be or likelihood of corticosteroid responsiveness. Not all patient responds to corticosteroid, and is an important reason to use FeNO to help decide who might benefit from steroid and who may not. It also helps to determine patient whose steroid therapy may be withdrawn if the FeNO is persistently less. That means the child is controlled with the asthma, with the steroid, and it's time we can decrease the dose of steroid. It has shown to predict the likelihood of steroid responsiveness more consistently than spirometer. So spirometric, bronchodilatory response, peak flow variability, or even the airway hyper-responsiveness to methacholine. So there are studies, and there are a lot of studies which have shown FeNO to be more helpful, particularly in children, in predicting steroid responsiveness and decreasing the dose of steroid. Let us just highlight some of the recommendation, because recommendation comes with a lot of very strong evidence with those. There are the NICE guidelines, the British Thoracic, the ATS, and what in summary the NICE tells us in the diagnosis of asthma in children. So consider FeNO test in children and young people aged 5 to 16 years, not below 5 because they are not able to perform the test properly. If there is a diagnostic uncertainty, for example, if you have a classical symptom and the spirometry is showing obstruction and reversibility, you are confident. But if there is a diagnostic uncertainty after initial assessment, that is, you are having persistent normal spirometry. So even an asthma patient may have a normal spirometry. So if you are having spirometry, how do you diagnose? You can use FeNO or an obstructive spirometry with negative bronchodilatory reversibility. A FeNO level of more than 35 ppb as a positive test, and you can confidently say that the subject is suffering from asthma. Suspect asthma in children and at young people, if they have symptoms of asthma and a FeNO more than 35 with a normal spirometry, a FeNO level 35 and obstructive spirometry but negative bronchodilatory reversibility, a normal spirometry, a FeNO level less than 35, that is 34, and a positive peak flow variability. In fact, variable airflow limitation is also another very good predictor of asthma. Diagnose asthma in children and young people if they have symptom of asthma and FeNO more than 35 with normal spirometry and negative peak flow, obstructive spirometry and positive bronchodilatory response, that is 35 being the cutoff. So what are the advantages? It's non-invasive, repeatability is there, easily can be used in patients, and by providing information about airflow inflammation, it adds a new dimension to the traditional clinical tool that we have for the diagnosis of asthma. For example, we have a lot being told that asthma is still now a clinical diagnosis, and clinical and examination is what is more important for the diagnosis of asthma. So how should I conclude about FeNO? In the setting of chronic inflammatory airway disease, including asthma, conventional tests just as FEV1 reversibility or provocation test. In fact, provocation tests are not easily available commercially or not done in most of the centers, are only indirectly associated with airway inflammation. They do not reveal about airway inflammation. So FeNO offers the added advantage of patient care, including, but may not be limited to detection of eosinophilic airway inflammation, which is very important tool. Why? Because by inflammation, you know who are the subjects when you want to use biologics, who are the subjects when to de-escalate steroid or escalate steroid. That is, determine the likelihood of corticosteroid responsiveness, monitoring airway inflammation to determine the potential need and unmasking or otherwise unsuspected non-adherence to corticosteroid therapy. For example, if you see persistently high FeNO and the subject tells that using the corticosteroid to the highest dose, you may think of probably non-adherence in those subjects. So thank you for your hearing, and definitely we can go on for some questions if just let me answer my screen.
Thank you, Dr. Haldar. As I see, there is no question in the question box. But I would like to confess that most of the pediatricians, general pediatricians, have a very sketchy knowledge about this spirometry. Not to talk about FeNO, of course. Even spirometry, most of us, we don't have a very clear knowledge. And your presentation is, though concise, is very to the point and quite informative. Thank you very much. Yes, you're trying to tell something.
Yes, there are numerous reasons why it is not that accepted spirometry, but now being taught in the undergraduate curriculum spirometry, now it is gaining more and more acceptance. The more we do spirometry, the more importance of spirometry will come to know.
Right. Okay, thank you very much.
Chetotpal,
yes, sir.
we have requested the DIP team to exceed another 30 minutes, and now it's over. So please give the vote of thanks and now conclude the session. Just 1 minute.
Thank you, Shakunda. Now, I would, before Dr. Nani Chakraborty delivers the vote of thanks, I would, from our side of the Kolkata Metropolis Academy of Pediatrics, I would thank Dr. Rathagiri, Dr. Basavaraja, and Dr. Pavan Kalyan, Dr. Tilak, as well as Dr. our very own Dr. Indranil Haldar. Thank you very much. Dr. N.G. Chakraborty, Dr. Nolida.
Yeah, thank you everybody for their enriched presentation, which will be definitely helpful for our day-to-day practice. Really, they make our presentation is a very nice one. So I am thanking CIPLA Respiratory Group for their sponsoring the program, and DIAP also for giving the use of platform. So I am thanking each and everybody, Dr. Ratnagiri, Dr. Basavaraja, Dr. Pavan Kalyan, Dr. Raj Tilak, Dr. Indranil, for their very, very, very good presentations, and thanking everybody for patience hearing and for present for a such long time. So I am thanking everybody.
So good night, everybody. Thank you all
Dr.
for your active participation. So, good night and see you soon. Bye bye. Thank you, DIP team Ohilasha. Now you can stop.
Thank you.
Thank you, DIAP team, for their